who I've never seen in the flesh before. Some people I've seen on Zoom calls or other things, and that's where you work out how Zoom deceives you about people's height. So it's really nice to see you, and this is, just to check you're not meant to be in the mums group over there. This is the fAD support group, because we have had people, I've certainly gone into the wrong meeting before now and thought half an hour in the wrong place, but it's really lovely to see people here. There is a program of brief talks, lots of time for question and answer. I always feel that that's just really an excuse to allow people to have coffee and talk to each other. So that's the most important thing from my point of view. And this is your meeting, so you interrupt away. If you don't mind, don't throw things, but you can say it's rubbish or whatever, and we'll just go through it. And we probably won't stick to time, and everything will be chaotic. And that may seem by accident, but of course it's by design. So, welcome everybody, and we've got a few bits of housekeeping. You won't be surprised, and then a talk about something that happens during the day, which is around poetry collaboration. So, over to Nikki and Paul. I'll get you to introduce yourselves for people who don't know you.
Thank you, Nick. Hi everyone, it's lovely to be here. I'm Nikki Zimmermann, I'm the direct support team lead. I'm just here to do some housekeeping because I think I'm the bossy one of the group, so obviously this is my job to do this. But first of all, we're just going to put pictures up of all the staff that are here to look after you today. So if you see anybody with a yellow, bright yellow badge on, that means they're a member of the team, so please go up to
Nikki,
them.
why does Seth get the film star? and the rest of us get the sort of...
It's the RDS pin-up ball.
Is that right? Nice one. Right there. I've seen him blush quite so much. He really has gone
Anyway, moving swiftly on to save sense embarrassment. So yes, so please, if you've got any questions at lunchtime and in the breaks, do find any of the staff and ask them as many awkward questions as possible that they can't answer. That would be great. Thank you. We're just going to go on to some housekeeping today. So the toilets are out of here and basically directly behind, so to the left. There are lots of other events on here today, so please don't go into the other rooms and get lost with the mums and babies and the astrology, because we think we're the best group here, so please stick with us. But that does mean the toilets might be busy, so there are toilets downstairs as well, so if you are struggling...
Don't talk to the astrology people.
So that's the toilets. The emergency exit, luckily today we're right close to the doors, so we're right at the front. We've not got a fire alarm that is expected, so if one does go, please follow us all and go straight out of the doors. We have the lovely Stephanie here for the National Brain Appeal. Give you a wave here. We are very lucky to be funded by the National Brain Appeal, who allows us to put on these fantastic events and does do some fantastic work as well. So please, if you've got some time today, please speak to Steph. She'd love to hear from you.
But do watch out, because she will get you to jump out of a plane for charity or climb Everest or something like that.
Or if you'd like to sponsor Nick to jump out.
I'll pay to avoid having to do that.
There we go. We have got on your seats, you'll see some poetry questions, which Paul's going to talk through in a moment, but also some evaluation sheets. We would love it if you could give us some feedback today. It's been years since we've been able to meet, feels like years anyway, in person, so we would really appreciate any feedback that you have from all the talks today. And one thing that we really need to add is we are live streaming this today. It's just pointing to us here, so we don't see any of your faces. So we'll be recording all the talks which are going on today. Just be mindful, if you're asking a question, your voices will be picked up. So please don't put any sensitive information or any confidential information in those questions, because it will be picked up and it will be available on YouTube. So just be mindful of that one. And now I'm going to hand you over to my lovely colleague, Paul.
Thank you very much. I'd like to also add my welcome, and this is my first time in the group, and I'm really, really pleased to be here. My name is Paul Kamek. I'm background very quickly as a clinical psychologist. I do some public health research work. I've worked with Seb and Nick for a number of years now, and we're particularly right now we're involved in the RDS Impact Project, which I know many of you may be part of already in different aspects of it. One of those aspects that we were funded to do was some innovative work, and we've chosen to work with poetry. Now, poetry and research may not sound like they go together. They seem very different things, and they are very different things. But one of the, I have to say, the grant reviewers were impressed because we gave an explanation of what we wanted to do with it. And one of the things we wanted to do is to get your words, the words from people with different rarer forms of dementia, as they are, to help explain and understand different aspects of the dementia journey. So we're going around to all of the groups that the RDS supports throughout this year, the large groups, and trying to collect your words. And I'll explain that process in just a minute. Some of you also may have been involved for 2 years in we call them the electronic poems, the ones that were done by email because of the pandemic. Well, that's finished now. We've got a book from that that's come out, and we're working to analyze that data. So this is another phase of the research publishing. So what we're asking is you have a sheet in front of you, and I know some of this is probably explained in the emails, but I'll be very brief. There are 2 questions. And the first is, how does this group support you? Is someone living with or living at risk of fAD? Or is a care partner for someone with or living at risk of familial Alzheimer's disease? Now, I know some of you, this may be the first time in your group, in this group, or you may be very new to RDS. So the second question may be more pertinent for you. And then if you were new to this group, how would you like this group to support you? What support do you need from this group? Now, what's going to happen when you write your words, it can be one word, a set of words that don't connect, or it can be a sentence. Those words we'll collect them today, and those words will be given to our facilitating poet, Lawrence Wilson, an experienced poet. He will create a poem using all or as many of your words as he can. He doesn't add his own words. So most times we think of poetry as authored by one person. And in this case, he looks at himself as a facilitating poet. And you are the co-authors, because it's your words he'll be using, not his. And you will get sent the poem to you when it's done with an explanation of his process to say what he did, why he did it. Also, your original words will get sent to you as well. So you'll see what the original words were and then how we turn them into a poem. He's also will do a recording, so you'll get this in audio as well as in written form. And if there's any questions at lunch, I'd be happy to answer those. You don't have to participate, I also want to say. We really would like you to, but this is it's optional. So if you could think about those words, I think I've gone through all the bits. Oh, at the end of the year, what we failed to say is that there will be a large collection sent to all members of Rare Dementia support of all the group poems. So you'll see what the poems, how they were created, what they were from the other groups. Now, when you're writing your words, I ask if you could probably do them as clearly as possible. I'm a terrible handwriter, as you can see from my scribbling. So our poet can see them because they'll be transcribed. But also think about words that might be emotives or emotions. That can be, we've had some funny things happen to talk about today. They can be whatever. Poetry is not linear, as we know. So anything that you want to put into it, anything, thoughts, emotions, and let the poet see what he can do with those. So anyway, thank you very much.
Thank you, Paul. I'm just going to quickly show the agenda for today. I'm not going to go through it all. We've got a fantastic programme today, which Helen's very carefully put together for us. It's fantastic. And just to say, at 12:30 to 1:30, we're going to have a break for lunch. We have got the courtyard garden, which we can use for lunch. They're very kindly to us these really nice little lunch boxes. You get one each. We did ask you all what you wanted for lunch, so that you can take your little lunch boxes. And if you're good we're going to hold hands and follow us around the corner because it's a locked garden and we have to go round just outside the road. But there's a lovely gate and will take us into the courtyard garden, which we can use for lunchtime. And then in the afternoon, we will have a break again, so we can have some coffee in the afternoon before we finish for the day. I think the next one, here we go, yes, we'll have a break again at 2:20, and then we will be finishing the day at 3:30, hopefully, maybe, yeah?
Well, we're ready. Between 3:30 and 6:30.
Nick said he'd pay for dinner for anybody.
Exactly.
Okay, I'm going to hand back to Nick now. Enjoy your day, everybody.
Well, thank you very much, Nikki. I'll try and not do too much wandering around to go off the screen. So there are people who I know are true experts in a way that very few people are, through lived experience of familial Alzheimer's disease. So I'm going to ask your forgiveness, because I'm going to do a little bit of a refresher or assuming nothing type of talk, because there are people who are here for the first time. So forgive me, and you can, check your phone in between if you want to, whatever. But when I was thinking about going back to basics, and one of the things, what did I think would be of interest to this group about familial Alzheimer's disease and the basic understanding? I'm going to give you bits of the background, but then I also thought, as I was writing my notes, I thought, actually, I just as well want to talk about, as well as telling you the things that are true, I want to talk to you a bit about myths. So I've picked 4, but I'm sure you'll be able to add to that. So I've got 4 myths. And then then when I did the myths, I then thought, well, actually, there are a few things that are almost myths. So I've got 4 half-truths. And then when I done my 4 half-truths, I'd really got into my stride. I thought, well, you see, you'll be here all day. And I thought, there are 4 things that I'll try and be polite in my language that I think are scandalous. So one led me to another. So you're going to get 4 myths, 4 untruths, probably lose my place, and at least 4 scandalous things. Probably find when I get worked up, the scandalous things will go on for a long time, but I'll do that. Okay, so here's the bit, as I understand it, that is true. I'm going to start with what is dementia, because that's very poorly understood. So dementia is no more specific than a diagnosis of, skin failure. All dementia means is that your brain isn't working as the way it should. And doctors define dementia as your brain not working as well as it should, to the point that it interferes with your normal activities of daily living, so what you would normally do, which varies from person to person. And there are many, many causes of dementia. They run from head injury to infections. There are treatable causes, and there are treatable causes that are broadly, the umbrella doctorate term is degenerative, where brain cells die. And all of us are losing brain cells from about the age of 4. That's all you need to do is see how fast a 3-year-old acquires language, and then try at my sort of age and learn a second language, and you realize how rubbish you are at something that you could do naturally then. So you're not so good. So that's a natural process, but there are some diseases that can cause brain cells to be lost faster, and those are called degenerative. And Alzheimer's disease is the most common cause, and many people, and in the press and in the pub or wherever, people will mix up Alzheimer's for dementia. For me, it's the same thing, and it's not. It's one cause, and Alzheimer's is a disease, whereas dementia is just it's a hold-all. And I'm getting into my scandals already, my outrages. One of the outrageous things is you would never go to your doctor and come away from seeing your doctor and be told you had cancer, and not be told what type of cancer, what stage it was, what the range of treatments were. But up and down the country, people are diagnosed with dementia, often without any tests, and left with no support. And that's absolutely outrageous. How could you ever make progress in research? Imagine trying to find treatments
we have phenomenal success in cancer. But a child with leukemia will not be treated in the same way as someone with a brain tumor. But what happened initially with cancer, when my grandfather died of the big C and my grandmother wasn't even told what it was all lumped together. And that when you can make progress in research. And Alzheimer's disease is a diagnosis of a disease where we can make progress because it's specific. In the same way you could make progress against leukemia or lung cancer. And we're in the transition from going from a totally useless diagnosis like dementia, which is non-specific, to Alzheimer's disease, which is better, but still broad in a way that lung cancer is broad, because there are different forms. One form of Alzheimer's disease, which Alzheimer's is overall the most common cause of dementia, it's typically something that happens in people's 70s, 80s, or later, is familial Alzheimer's disease or inherited Alzheimer's disease. And it's usually early onset, can be as early as 20s, 30s, 40s, but it can be late onset as well, 60s, 70s. And doctors, what do doctors mean by early onset? Well, late onset, it's just arbitrary. It's when symptoms are obvious before the age of 65. That's called young onset or early onset. And there are many different forms. So Alzheimer's disease, there are two key proteins called amyloid and tau that get deposited in the brain. And the brain's pretty good. It's got a really good sort of clean-up system. It's like street sweepers and clearing up rubbish that gets produced and the people take away our garbage and our recycling. The brain's really good at that. So cells are always putting out bits of protein, and there's lots of mechanisms for clearing out and getting rid of it. And these two proteins that shouldn't stay in the brain build up, amyloid and tau. And actually, Alzheimer, who gave his name to Alzheimer's, was a doctor more than 100 years ago. His big paper was in 1906. And there's one Alzheimer researcher who I wouldn't believe bought a license plate which says 1906. I don't understand why people buy personalised number plates. Why would you buy 1906? Anyway, he did. 1906 was the year that Alzheimer was doctor, to give him his proper term, because he was German, so they like lots of titles. He was Herr Dr. Professor Alois Alzheimer. I think that's fair, Betty, isn't it? Isn't it in German, people like lots of different names. And he looked down the microscope, really developments in German lens technology, and saw in somebody who'd had an illness with memory and thinking problems in their 50s, and saw these, drew pictures of these proteins which we now know are amyloid and tau. So that's the background to the disease. When did we start realizing that it could occur in families? Probably in the 1930s, the first families were described, where I thought this is occurring more than by chance. But it wasn't until really the first gene was found in 1991, so it's relatively recent. And a genetic form of Alzheimer's disease accounts for less than 1%. You all know how rare this is. Less than 1% of all of Alzheimer's disease, so it's very, very special form. And first one gene, and then another gene was found. And I'm going to talk a little bit about the genetics in a moment, but for the first gene where an error was found, actually was found by colleagues I work with now, John Hardy and Martin Rosser, from families that started to form the first support groups, actually. People may know of Carol Jennings, and she wrote an amazing letter to John Hardy and said, I saw that you're looking for families. I think my family might be of help. And her family, blood samples from her family, led to probably one of the most important discoveries in Alzheimer's disease ever. Probably more important than Alzheimer's initial discovery itself. Because when you know a gene, you know what it does. It makes proteins. If you know what proteins it makes, you know how it can interfere with brain cells. If you know that, then you can design treatments. And the genetic forms of Alzheimer's disease, which this room represents, is, I absolutely believe, and there's already evidence for it, is the key to the cure for Alzheimer's disease. It's the most understood, the most tractable, the most treatable. And this is a really exciting time. You'll hear from Cath and Laura about how it is a time. When I first qualified as a doctor, I worked on an HIV ward, AIDS. People came in, we treated their acute illness, they went home and they died. And then treatments came in. And the first treatments weren't very good, and they had side effects. Now, does anybody know what the life expectancy for if you get diagnosed with HIV/AIDS now is?
Normal.
It's normal. Some people say it used to be 4 years, and then it was much longer than that, and then it was normal minus 4 years, which was a turning point, and now it's probably normal. And this is the cusp that I think we're on with Alzheimer's disease. So there are 3 genes: amyloid precursor protein, which was the first one that was found, or APP, and 2 other genes, which are actually sort of variants on the same. One is very, very rare. They're called presenilin, because pre-senile, so young, causes young Alzheimer's. Presenilin 1 and 2. So those are the 3 main genes, some very rare things as well, that cause an inherited form of Alzheimer's disease. What do I mean by inherited? Everything about us is inherited. Well, nearly everything. Maybe not I don't know, choice for coffee or not, but probably that is too. But there are some things, like our height, that are very multifactorial. There are environment and there are genes. And there are hundreds of genes, thousands of genes, that determine our height. So don't complain to me if you're not happy with your height. You know, that's lots of your genes. And of course, environment. People who are malnourished have a lower height. So that's a mixture. And interesting, there are some countries where height has hugely increased. That's what we call a polygenic or multiple genes and environment disease, trait, height. But there are other things, like having brown eyes. That's inherited in a dominant way. What do I mean by that is, if you get the gene for a brown eye, it doesn't, from your dad, let's say, it doesn't matter that your mum gave you a blue eye gene, you will be brown-eyed. The difference between diseases like Alzheimer's disease and blue and brown eyes is you see the effects of your brown eye gene, not at birth, but very shortly afterwards. Whereas other genetic disorders can have effects on people in their 90s, or in their teens, or in their 20s, 30s, 40s, 50s. And so what happens with these genetic forms of Alzheimer's disease is there is an overproduction of a form of amyloid that's more difficult for the brain to clear. And that builds up over 20 years and then starts causing the neurons, the brain cells, not to work so well. That's pretty much all of Alzheimer's described then. Really good bit of news, which may seem a bit frightening, is that, which we didn't realize, and Alzheimer himself didn't realize, is that it takes a long time for the amyloid to build up in anyone's brain to cause any trouble. So what that means is we know that you can be perfectly normal, cognition normal, memory normal, with a lot of amyloid in your brain. So that means as long as we can stop the consequences of the amyloid, of course we'd like to stop amyloid even going in being deposited in your brain. That would be great. But if we can stop the consequences, people can be completely normal or live with the sort of normal effects of aging, which, if you're anything like me, you forget everything, can't remember names and faces. So but we manage, don't we? Like a number of people where glasses in this room, your eyesight's not as good as it once was, but we find workarounds. Okay, I'm going to stop there because that's the background. Does anybody want to ask me anything on that? Or are you too excited to hear my myths, half-truths, and sheer scandalous things? Do you want to hear those, or do you want to ask any questions? Any questions on those? Okay, too excited by the myths. Okay, myth, and this is the embarrassing participatory bit. No poetry, but if you can make it poetic, that's great. So I want people to add some myths, untruths, or the things that make them angry. Because my scandals thing, because otherwise I would have used expletives, are the things that make me angry. So myth. I look like my mum. My mum got Alzheimer's, so I'm going to get Alzheimer's. Has anybody thought that? Yeah. Not true. Not true. The gene, whether it's your brown or blue eye gene or your Alzheimer gene, has no idea what the rest of those genes that sperm and egg have put together to make you. They don't check, they don't confer. So what do you think? Do you think brown eyes would go well with this? No, they don't. Hi, come on in. We're on me doing my bit on myths, untruths, and scandalous things. So you come in at the moment where I'll probably need to be sort of fan. So the only thing you can say is if you do not look at all like your mum or dad, maybe they weren't your mum or dad. And if they weren't your mum or dad, they have not passed any genes on to you. That's much more common than you might think. And it was particularly common. There was a spate of where lots of genetic illnesses didn't seem to work with people who were born in the early 1940s in the UK. And we can thank the American servicemen for that. People away at war coming back and finding, this isn't quite what I expected to come home to. So that's one. So the looking like, if you really think your mum and dad, don't say it was me that suggested that, please. Non-paternity is more common than non-maternity, though it does happen as well. People have a child and pass it on, particularly if they're at a very young age, pass it on for somebody else, and it's passed off as my sister's, so that does happen. But non-paternity, American servicemen does happen. Myth number 2, in my family it just affects women. In my family it just affects men. Anybody thought that? Good. Not true. There are some genetic things that are inherited just like that, but not the Alzheimer genes. So no more likely. Even if everybody in the last 57 generations in your family has been a woman who's been affected, it's no different. Okay? That's myth number 2. Myth number 3, which I really kind of call assuming the gene has a memory. I have met people where there's 4 of us in my family, my older brother and sister, they didn't get the gene. So since it's got to be 50-50, me and my sister are going to get it, aren't we? Not true. Absolutely not true, but people all tend to think it. And the best analogy is, if you toss a coin and it comes up heads, you pick up that coin and you're about to toss it again. What's the chance of it being heads? This is the participatory bit, but 50%. Thank you, Nicole. And it doesn't matter if there are 15 heads have gone before, it's probably a dodgy coin. But it's actually, and the gene works like that as well. It's every time, it has no memory. It just flips each time. Another myth, it gets earlier. It's sort of my granddad had it at this age and it's got earlier. That's a myth. There are some genetic illnesses where that does happen. And one of the reasons it is, I put it in the myth rather than the half-truth, because there's a half-truth to it, is that people in the past had their problems dismissed. It was shell shock in the war. It was, they had a breakdown. There was something else. And so it gets missed. And nowadays we're better at that. So it may seem like it's become earlier in your family, but actually it doesn't. And since this is the last bit on the myth thing, is you get it at exactly the same age your mum or dad did. That's not true. And it's often used to justify trials. But actually there's quite a lot of variability. Yes, of course, if your mum or dad got the illness at 50, that's roughly the sort of age. But it might be 40, it might be 65. So it's not like, it's not really an exact time bomb set to a timer. It's a risk that happens at a particular time. Okay, untruths. Brought on by a shock. Brought on by a head injury. Yeah, of course, there are things that aren't good for your brain. Don't go heavyweight boxing. I mean, that's not really... Sorry, Mike, apologies. Mike, do you mind me outing you? Not that he's a heavyweight boxer, but Mike does sports writing and has got interest in it's fair to say, interest in head injury and sports people. Things like that.
Rugby.
Rugby. Yeah. But things that hit your head are not good for you, and if you have anything that damages your brain, your reserve of coping with things, symptoms probably may well come out early, but it's not brought on by a shock or emotion or somebody not being nice to you. Another myth, or half-truth, nothing you can do. That's not true. There are things you can do, and we don't really understand the contributions of environment, but sort of living in a sort of healthy, cognitively, physically is actually it's a good thing to do. If you've got the gene, you will 100% get it. Now that's a half-truth, because that actually is what we used to teach. But we found, and this is an amazing bit of research, is that in rare occasions, and initially it was thought to be mistakes, somebody hadn't really checked the gene properly. People have inherited another gene that counteracts, that knocks out that genetic effect. It's rare. So I think, in the sort of homespun advice that you have to prepare for the worst but still hope for the best. You still have to expect this gene in any family to affect people at a particular age. But there are a small number of individuals where the gene has been checked and checked and checked again, and they've got the gene, and they have lived decades beyond their parental age. And in a number of cases, we didn't know why. And now, for the first time, we're finding out that there are some genes that negate the effects. And that also is a great source for hope. We'll come on, I think will we talk a little bit about gene therapies later?
Briefly, yes.
Okay, we can pick up on that. So I think it's really, really exciting, the thought that you can inherit a gene that will counteract the effect of the other gene, and technology that's allowing us to knock out or silence genes is one of the most, I feel I'm just, risk of getting emotional. I think it is amazing, just absolutely amazing, and there's great hope there. There are no treatments, another half-truth. There are treatments, absolutely, there are treatments that are well tested, that help people's function, let the brain cope better with any damage or dysfunction caused by amyloid and tau. They're not wonder drugs, and there are also therapies for the first time ever. I've been doing these meetings for a long time. First time I can say to people face to face, there are therapies that have been licensed that are thought to stop amyloid building up in the brain or get rid of the amyloid. And that is amazing. And that is the culmination of almost 20 years. We were part of the very first trial which was using a vaccine, which had to get stopped because it had too many side effects. But when people's brains were examined, there were patches of amyloid that were completely removed by the vaccination. And we've seen what we could do with COVID, go from no treatment to treatments, vaccinations, all sorts of things. So I think that's great. Now, the scandalous bit, and then I've already totally destroyed the timing, but that's okay. So number one, scandal. Oh, the fake treatments. Who has read on the internet about a particular diet or a particular treatment? Anybody here? Scandalous. They're just making money, and they are, well, I won't say what I think of them, and they're just exploiting people's desperation. And so, one example, somebody that one of our patients involved with, they could go to Belgium, don't know why Belgium, I've not got nothing against Belgium, and they could get stem cells injected into their abdomen. No evidence it was ever going to get to the brain, no evidence it was going to help, there was no data behind it, and that would cost you 30,000 euros, plus all the rest. The great thing is, if it didn't work, your second dose would be half price. So, you know, there are people who give diets, specific diets, which may have some benefit in them. Not much evidence for it. But in order to get on the diet, you have to have very expensive tests of your magnesium and all sorts of totally irrelevant things which cost you thousands of dollars. And their scan, even if you've already had a scan here, for example, which also costs you thousands. I need to be quite cross. So that's number one. Number two are the scams. So my mum had Alzheimer's, and she ended up with 3 sets of home insurance. They wouldn't have paid out if the house didn't burn down. But if it had burned down, she wouldn't have got 3 payouts. So there are all sorts of scams that's scandalous. I'm warming to my theme, you can see here. The lack of funding is just shocking for research and for care. The cost of dementia is more than heart disease and cancer put together, and 6 times as much money goes into cancer. Not that I want a single penny taken away from cancer. The total cost of dementia to the economy is 26, 28 billion, people don't really even know. £1 of the cost of dementia to the economy, what proportion of that pound goes to research to try and stop it? Half of 1 pence. It's like the roof of the house is leaking and we're spending all the money with the buckets.
Is that worldwide or globally or nationally?
So that's nationally. It's slightly better in the US now, but it was very similar all the way around. That's the UK. Shocking. The lack of support for people with care, that's the most shocking of all. You battle, don't you, Erica, to get CHC. You battle to get somebody to provide help. And we've got to change that. And that's it. Okay, I think I'm so over time now. I will probably get people to save their myths, untruths, or other things to when we have lunch or Q's and A's. So Cath, you're next up, and Cath is going to talk about what's next for the dominantly inherited Alzheimer networking trials. And I hope Cath doesn't need any introduction. She's my very, very close colleague. Her office is next to mine, and we can each hear each other rant on the telephone because the walls are not very well done. But when you occasionally have one of us come out with a knock on the door and say, "Can you believe?" So, okay, Cath.
How to follow that, Nick? Thank you. Myth number 5, we're capable of keeping to time. There is no agenda
I don't think there's any myth there.
Which now means I am entirely free to diverge at all times from anything I have to say. So feel free to ask questions if you want to. We've got time afterwards as well, though, so plenty of time to go through things that I don't get onto here. First thing I want to do is just take a step back. I was asked to talk about the DIAN TU network, which I'll mention briefly in a second in terms of those of you that maybe haven't heard of it. But coming back to Nick's point about being on the cusp, it's absolutely right. And he stole my line.
Oh.
It's absolutely right. We really are on the edge of a complete change, I think, in our treatments. And when you think about what's been happening and the myth that there are no treatments, which Nick has rightly completely busted up, over the past 2.5 years, we've all been through hell. Throughout that time, trials have continued, trials have expanded. There are more trials now in Alzheimer's disease than there have ever been before. So we have kept going throughout. And not only have we kept going, but there has been, as Nick mentioned, the first ever disease-modifying therapy. Couldn't say that a couple of years ago. And I've got goosebumps just saying it because we never thought we'd be able to say that before we retired. Now that treatment isn't fantastic. It doesn't make huge changes, but it makes a modest difference, we think. And it's the first. And you've got to have the first to get better. And it was the same with cancer, it was the same with HIV, as Nick mentioned. When you've got that first one, then you get more funding, then you get more interest, then you accelerate your research, and you're at the beginning of what is a very different game. So I think that's the place where we really are right now. We have 4 drugs that all show significant changes in dropping down the amyloid in your brain, allied to changes in other markers of disease in the brain. In other words, it doesn't just change the amyloid, it changes the disease biologically, allied to mild cognitive changes in some of those. So that's amazing, and we have to build on that now. So I'll come back to that again in a second, but that's one major change since we all last spoke actually face to face, which is incredible. The other thing is, Nick just mentioned gene therapies, and that's really important for genetic diseases like autosomal dominant Alzheimer's disease. And we dosed the first patient with a gene therapy in October 2017. I was terrified. The idea of giving a gene therapy to somebody with Alzheimer's disease is kind of like, what are you doing? That trial has now finished, and that was in standard Alzheimer's disease. It's finished, and the first results showed that it did what it said it would do on the tin. So it dropped levels of tau in the fluid, of the spinal fluid, which suggested that it changed the disease in the brain using a gene therapy. So if we can do that in standard Alzheimer's disease, we can target that in genetic Alzheimer's disease in a very precise way and really start to look at how we can properly change the disease. So I think that's incredibly exciting. So just those 2 things, which are not what I was asked to talk about at all, but I think they're really important. So those, by the way, I'm very happy to answer any questions you like on, because I think they're really, really important. So back to the network. Can I have the next slide, please? So I know some of you, there we go, some of you will be very well versed in DIAN TU. Others of you won't know what this is. This is a really global collaboration. You've heard already about how rare autosomal dominant Alzheimer's disease is. So if you want to find a treatment and you want to find something that works, you have to have a lot of people. And the only way to do that with a rare disease is to have a global collaboration. And Nick was integral to the conception of this idea. He co-wrote it. And latterly, I've been involved in helping lead from the UK side, the trial side of this. Started with an observational cohort and then built into treatment trials using what we understand about those cohorts. And what you can see here is just how widespread that is. It's throughout the world. And this really is, and those of you that are involved will know, this is a community where the participants and their families are on the steering committee. They get to say what should happen and shouldn't happen. They influence how it works. They're engaged in what changes. And we'll hear maybe from Laura a little bit more about this and other things later. But I'm just showing you that to show that this is something we have to work together across the world to make a difference, which is what we're trying to do. Next slide, please. And what we're trying to do in the network is have different opportunities at different stages of disease. So in standard Alzheimer's disease, the drugs are all tried way down the line when people have had symptoms. They've had amyloid in their brains for 20 plus years, they've got symptoms, they've got a lot of damage in the brain. What we've been trying to do in the DIAN to use trials is something called secondary prevention. So you've got mild or no symptoms, and we're trying to prevent those symptoms developing and progressing. There is still pathology there, the amyloid is still in the brain, but we're trying to prevent it getting worse. And now, and I'll come back to this later, we are looking even earlier, and some of you will be involved in this. I know I've seen a couple of faces already. So trying to prevent that pathology, that disease actually occurring in the first place. So we can do this in a genetic disease. We cannot do this at the moment in a disease where we don't know that somebody's got the gene that causes it. And that's the first time that that's ever happened with dementia. So it's really exciting. You can just move on. So that's me just repeating myself next and next. There we go. Nothing like repeating yourself, but therefore as a memory doctor. So the first ever study that happened in DIAN to used 2 drugs against amyloid. So these were antibodies that effectively were injected and mopped up the amyloid. That was the aim. Touched the amyloid, mopped it up, and the idea was to prevent that getting worse. And this was a study, it started at 2 years, it went on to 4 years. It was the first ever study to try and do this in genetic forms of Alzheimer's disease. And you can see how long ago we started this study. So way back when, 10 years ago, Nick, that's a very long time. We started this, and some people who are here, I think may have started at that very beginning. And that study completed in November 2019. And I'll get to the results in just a second. There was a lot of learning that went on, and that's the thing with these trials, is that we understand more over time, and that knowledge is actually quicker in some ways than the length of these trials has to be. So we have to adjust the trials as we go along to take on board that knowledge. So here it was, that we weren't giving enough of the drugs and we had to increase it halfway through. Next slide, please. So these drugs, unfortunately, did not show a positive result in those 2 arms in terms of what we call the primary endpoint. Did they change your cognitive decline over time? And the answer to that is that they did not, which was very disappointing. The second result, next slide please, was more promising. So I said at the beginning that these drugs are starting to show an effect on disease process. So gantenerumab, which was one of those 2 drugs, showed a reduction in amyloid in the brain. So it cleared out the amyloid from the brain, but in addition to that, not only did it clear out the amyloid, it showed changes in different markers of disease. So again, it showed a change in the course of the disease and a change in the rate of degeneration by dropping the amyloid. So that was really promising, but why didn't we see a cognitive result? Next slide, please. And basically, we think it was, we took the drugs they were too low to start with, didn't take them up high enough, soon enough, and they weren't up high enough for long enough. And it's very difficult sometimes to measure those cognitive changes when people are essentially asymptomatic. We need to get better at how we measure those very subtle changes in people when they're very early in the course of the disease. And the bottom line is, although this is an international effort, we think probably because the drugs weren't taken up early enough, it didn't have enough power to show change. But it showed promise. Next slide, please. So it's gone into an open label extension, and some of you are in that study. And the reason for that is because we saw that promise in those markers, and we need to see what happens over a longer period of time at that higher dose and take the doses higher further, which is what's happening. And we have 8 people in our unit that have gone on to that study. And there are some challenges with that. To go into that study because you're being given drug, you had to know your genetic status. And that's not a trivial thing, clearly. The previous study, you didn't have to know your genetic status. And this is something we'll probably come back to again in other studies because it is a complexity of going into these things and something that's really important that we support people with and that they make the right decision for them at the right time. The study is 3 years long. As a lot of you will know, it has these extraordinary annual visits, which are 5 days long. You live in 2 hotels, have 3 PET scans, an MRI scan, cognitive tests, and a partridge and a pear tree. But it is actually now much more manageable because we can see people at home. We can give the drug at home. So if they don't want to come into the units, which some of them still do, which is great, we can make it easier. And as I said, we're escalating the drug over a long time to really high doses to see what happens and whether we can really match that biological change with a cognitive change. Next slide, please. So this monster is what DIAN TU network actually looks like. I've just been talking about these two drugs, and they finished there, and this is the open label extension where everybody's getting the drug. Then this briefly was a trial that stopped with a drug that actually proved to be toxic. We didn't put people in it, but this sometimes happens in trials when you try new drugs. And there are a number of you that are now in what we're calling a cognitive run-in phase. And this is basically a trial without a drug, where you go through the same sorts of tests so that we really understand your profile, so that when you then get the drug, it's optimized in terms of its power. It gives us the best chances to see a result. At the moment, that's happening for 2 trials. But basically what you're seeing here is the next phase of DIAN TU. And Nick mentioned tau as well as amyloid being the important things that we want to try and target. This was about amyloid, these are about tau. Trying to change the tau levels in the brain to try and prevent the disease progressing. And this I'll come back to later, which is doing the primary prevention really, really early before anybody has symptoms or pathology, trying to prevent it ever happening. Next slide, please.
Just Cath, just,
Yeah.
well, just in case it wasn't clear to you.
Yeah.
The base inhibitor, which was toxic, it's toxic can mean, you know, people were dying like flies.
Oh,
It wasn't like that at all. No, it just.
Sorry about that. Yeah.
It didn't have a beneficial effect.
Yeah.
Actually, nobody died. Nobody.
No, nobody died. It basically just, we monitor so many things while you're in a trial. We monitor your bloods, we monitor your brains, we monitor how people feel in many, many ways psychologically. And this showed a slight change in liver function, basically, that they didn't feel was something that should happen. And some people showed a change in cognition that was surprising, that reversed when they stopped the drug. So nobody died. But those are things that we have to take into account whenever we're doing a trial. You know, what is the risk and benefit balance, and what are people happy to tolerate? Next slide, please. This just shows you where we are in the league table. So you'll see this star here.
Not that Cath is competitive at all.
Yeah, sorry, you got a question.
Because
Yeah, it's in relation to the early side.
Yes.
Is there a connection between the East Side trial, the bit that we can see in the middle there, and the earlier, I can't pronounce them.
Lily and Roche.
Yes.
The difference, so it's a very good question because it is confusing. So these are 2 drug companies that each produce this drug. So Selina came from Lilly, Roche came from gantenerumab. Eisai, and I'll get to this in a second, co-produced with Misery, I'll tell you later, the new drug in here, E2814, catchy title. So it's basically a drug company makes a drug, and in DIAN TU, unusually, they have a consortium of different drug companies that will allow us to work together with the different drugs in one group. Most studies only allow one company, one drug, one trial.
And it's also unusual in that the companies have to, normally a drug trial is done, the company decides to do a trial, correct me if I'm wrong, Cath, and then they, you know, as long as they get approval, they just do the trial.
Mm-hmm.
But because familial Alzheimer's disease or autosomal dominant Alzheimer's disease is rare and so special, they have to persuade a group of experts, which includes patients, that this drug rather than that one.
Yeah.
So it turns things upside down.
Yeah, which is very
Most
healthy. That collaborative feel is much healthier than, you know, being told what to do by fun. So yes, I'm not competitive at all. That's why there's a star here. So basically what this is the cognitive run-in. And those of you that are in it, you know what that's like. That's the trial without drug. So having your scans and cognitive tests. And it's how many people by site have been enrolled. So you'll see the Washington University is up here. So this is the home site. So you would expect them to have these things. Actually, no, they haven't. We're here. We seem to be doing pretty well. The one thing I would say that I'm slightly unhappy about and we need to try harder is that our friends and neighbours in Amsterdam are winning. So Jane and I and Helen and others will be working very hard. I know there's a list of people, and some of you may well be here, that want to get into the studies, to help get you into the studies and get that star. That. Anyway, move on quickly. So I mentioned the tau trials, and the first one is about to start. So tau next gen is all around trying to treat the tau, move on to the next one please, instead of the amyloid. And this is because we know that tau is needed for amyloid to be toxic, right? If you haven't got any tau in there, the amyloid isn't toxic. It changes the disease. And also, we know that it builds up as your symptoms build up. So it's correlated with how the disease progresses. So if we can treat it and we can remove it, the idea is we can prevent that build-up happening, prevent the disease getting worse. Next slide, please. So we're targeting tau. Back to Eisai. So this is a drug, and this is a treatment trial that's the precursor to the DIAN bigger trials. Basically, this drug is an immunotherapy like the amyloid drugs. It's an antibody. Instead of targeting amyloid, it targets tau. It mops up the tau and removes it. And what's exciting is that this drug was developed by a colleague of ours at UCL, at our site, from scratch, with Eisai, and that we led the trial. And I think it's really fantastic that we've been able to do that right from conception of drug to giving it to people with autosomal dominant Alzheimer's disease in the same place. So we're quite proud of that. This is a phase 1 study, which means it's a safety study. It's not being given to patients or participants before. We are testing to make sure, we're very careful about it, that it's safe and that it engages the target. In other words, it does what you hope it does biologically. And we started this last year. We got the first 4 patients in the world. And there's only other 3, not competitive again, there's only another 3 in the world that are into it. So the majority of people are from our site. And so far, I'm delighted to say everybody is very well. It's been completely safe, which is the most important thing. And what happens is the results from that study will feed into the phase 2 bigger study. So this is the one where we're looking at safety and whether it works in a larger number of people with genetic Alzheimer's disease. And that's people from the cognitive run-in that will go into this study. Next slide, please. Now, things have got a little more complicated. As I said at the beginning, that there have been these drugs that have shown some effect, amyloid drugs. As a result of that, the DIAN team thought that to give people the best chance of making a difference to disease, they should combine treatments. So not just the tau Eisai treatment, but add in a drug that also targets the amyloid. And so we've just made things much more complicated for ourselves, but hopefully we've given people the best chance to make a difference by reducing both the amyloid and the tau in the brain. So coming back to HIV treatments, the reason they started working was they were a combination. One treatment on its own didn't work so well. Adding in more against multiple targets worked much better. So that's the hope. We'll see. This is the first time it's been done. But basically, instead of it just being a tau treatment, it's an anti-amyloid treatment. Next slide, please. And sorry, this is complicated. So depending on, I won't dwell on this because we can go through it in detail later if there's time. I realise I'm talking far too much. But depending on whether you have symptoms or no symptoms, with your autosomal dominant Alzheimer's disease, you have a different form of treatment or a different order of an anti-amyloid and an anti-tau treatment, but you eventually have both. And this is the study that we are starting in coming months. It's currently in ethics, so it'll be about 2 or 3 months before it starts. And next slide, please. It lasts, like these studies do, and you'll know if you've been in them, they last 4 years minimum. People that go in early are often in much longer because it finishes at the same time, so it can be up to 7 years, which is a big commitment, so we have to make it as easy as possible for people. So we have home visits. We make sure once you're safe on the drug, then you can have it at home, you don't have to come in, you only have to come in infrequently. this is an important thing, and I think that this is difficult, and we have to just express that, because you have to know your mutation status to go into this study. That's not for everybody. And I think the timing of that is really important to get that right for the individual. And we are very much here to help support and discuss with people how they feel about that and help them go through that journey. As I said, that's a choice. It's not right for everybody. And I do think it's a challenge. In addition, the visits are frequent, and I can see Nick here and various other people who are having 2 weekly visits at the moment and probably dosing with other drugs. That's quite a frequent thing to have. So again, it needs to fit it into your life. And it adds complexity, but again, I think it adds promise. So next slide, please. You will know, those who are in DIAN, that's what a week visit with a partridge and pear tree looks like, roughly, effectively. There's a lot that gets done. Like I said, it's once a year, and the other things, the other visits are much less onerous. So that's the first drug. That's the immunotherapy against tau, that's Eisai, with amyloid. There are others being looked at. Genetic treatments, I just want to emphasize, this is something that's likely to come up soon. I told you we're investigating one in standard Alzheimer's disease. There are others that are very likely to become available very soon, but I can't say any more than that at the moment. And we are likely to be a site that does these very early phase studies, like the one I just told you about with Eisai, and we will always keep you posted if you're interested in finding out more about those. And I would talk about primary prevention, but Nick, have I got 2 minutes? 2 minutes. So this, I think, is incredibly important, because this is taking things way back before you even have pathology. So it's decades before you might have symptoms. Next slide. And this is very early days. I haven't seen a protocol yet for this, okay? This is stuff I nicked off Eric McDade. The aim is, again, use an anti-amyloid therapy as early as possible to prevent the amyloid ever building up in the first place. Any of that cascade of things happening we've talked about, prevent that happening. It's going to be a 2-part trial, and it will have the first part where you don't have to know your genetic status, where you will or won't get active drug. It's going to be a randomized controlled trial, and it will be like previous ones, more chance of having the drug, less chance of placebo, but there's still a chance. And then if that is promising, it will go into a second part, which is the open label extension, where everybody gets the drug. Next slide. That's due to happen in this country at some point next year, probably around the middle of next year. And as I said, you don't need to know your genetic status to go into it, though you might need to later. Next slide. Back to the monster. Next slide. That's it. There is a lot going on. And any questions you have, please ask them later.
So that's amazing. This is top tour, and as you said, your talk would be much shorter 5 years ago, which is a good thing. So I understand that you're going to talk about experience in conversation of taking part.
Absolutely. Well, we need an expert, and that's not you, and it's not me, and it's Laura. So,
Laura, are you?
So if we can get 2 chairs, yeah, that would be nice.
Check that you can see yourselves on the screen.
Oh gosh.
Then
That's already.
don't look again.
Just my head poking out.
Oh, luckily we're about from here up.
Perfect.
Is that okay? So, I'm sure most of you know Laura, but do you want to just introduce yourself?
I'm Laura, I'm from Norwich. I have been with the trial for 7 years. My dad is the most prominent part of my life that sort of brought this into my world. He had early onset Alzheimer's, and I started this sort of weird journey without thinking too much about it, and now I'm here.
Do you remember when you first thought about going into the study? Do you remember what that was like? What sort of thoughts were going through your head?
It's interesting. I didn't it didn't start for me as thinking about going into the study. It started for me as thinking I want more information about what I think I've overheard and snippets about what's gone on in my family. I was living in Australia at the time, and it was a real battle to find the right person to give me that information. And eventually I did, and they said that from what you've pieced together, it seems to be that if you did carry this gene, then this is what would happen, and sort of clarified that information for me. So then I just thought, okay, well, now I have this information, what do I do with it? And they said, you've got an option of being tested to know 100% or not. And at that stage, I thought, I'm not in a position where I want to be tested. So I just asked on a whim, is there anything else that I could do? And the doctor said, I believe there's a trial going on that's founded in Washington. Would you like me to find out some information? I said yes. I left the room at the hospital and went to meet a friend for some cocktails, and I got a phone call about literally hours later saying, would you be interested in being in this trial? And there was a lot of components that had to be in place for me to be eligible for that trial at that time, in regards to the difference in my age from my dad's early signs of decline. And everything just seemed to match up, and it felt just weirdly like it was the right time and the right thing to do. And it helped me feel like I had some control and information about what had been clarified to me to be true.
That's interesting. So you mentioned the control feeling. What was it that gave you that feeling about being in control?
I guess doing something with the information I had. I think information provides you with a lot of power. And sometimes even if you can't do anything about the situation, if you understand it a lot more, then that gives you some element of control and more peace of mind, maybe. And to know that there is something going on. There's something in the wings that is fighting for a change to something that's had such an impact on your life.
It's not bye-bye, there's your diagnosis.
Yeah, exactly that.
Did that feeling change? Because 7 years is a long time.
It's weird, it doesn't feel, I can't even believe that's how long
Neither can I. So, but is there a way that things change over time? There's sometimes when it feels more positive than others, or is there,
I think
staying the whole time?
sometimes it feels maybe it has more of an impact than others. I think that's in conjunction with just more everyday life stuff that goes on. Like anything, that the busier you are or the more stressed you are, if you have to do something additional on top, naturally that does make it a bit more difficult. I've always gone with the approach of, I almost don't give it too much headspace. I don't hand out and say, I don't read everything that's always sent to me. There's obviously so much literature and paperwork involved in these trials, but I don't actually read it all. I trust the process and the people that I speak to, and I turn up and I do what's asked of me. But outside of that, I just continue doing my life and my thing. And that's the way that it feels like it's not really fluctuating in how,
You've managed it around your life rather than it taking over your life.
Exactly
I think that's really important.
Yeah.
Okay, and if somebody was thinking of going into a trial for the first time, is there any advice you'd give them, or is there anything you'd suggest to them?
One thing that sticks out in my mind is when I started it, I feel like there's a lot of cloak and dagger and shame, and I don't know why, around dementia. And my personal experience, not many other people, no one else in my family really wants to open the door to information about it. And you may think that, well, if I do this, I'm going to have to, there's no denying that the time it requires of you, you're going to have to potentially tell an employer, and I initially thought, how am I going to ask for this time off or schedule this into my life? But I found it quite empowering to actually say, this is what's happening, this is something I'm involved in. And the chances are, no one's going to turn around and say you can't do it because they'd be a really hard arsehole.
That's so true.
And if I was going to wherever I was working at the time and say, there's cancer in my family and I'm part of something to enable that, nobody would have a problem with saying that. So I do feel like why should we? I don't know if it's common for everybody, but I just feel there's a significant difference in how we feel about it and how it's discussed and the awareness. So I was worried about that, but I did find that actually quite empowering. And what was the question?
It's around advice for people thinking about whether they're going to go into this or not. And that's a fantastic point you've just made, by the way. It's better than it used to be, but it's still way off where it should be. So you're so right.
But that's the only way that obviously it's going to change is the more people that get involved. And this isn't like a selling pitch to you. I personally have not looked back, and one way that what's asked of me and things are just going to constantly move in one direction. It's not suddenly going to come to an end. I've just sort of assumed now that for the rest of my days, this is what I'm going to be involved in.
Yeah, you don't get to leave once you start. That's it. Part of the family.
But everything that's asked of you is done in a way that is made to be as simple and streamlined as possible, and it really is. And I now have the home visits, which is a complete game changer.
Yeah, they make a big difference.
Yeah,
they really do. You very kindly said that you would be happy to take questions or try and answer questions from
Try.
So I just wondered if anybody's got anything they wanted to ask Laura, because she knows so much more about this than I do from the point of view of what it feels like. And that includes you, because I know you always like to ask questions.
Which trial are you on?
And you can ask me that, and can you answer?
Yes.
No, you're fine.
So Laura's on the open label extension. So she's getting the gantenerumab and she's escalating to the high doses at the
And
moment.
it has kind of hoiked up quite quickly over, and again, I just have to trust that process. So now I'm every 2 weeks at home with an infusion into my stomach, which takes about, the actual infusion part, I've got about 10 minutes. A nurse turns up. It does look a little bit like we're dealing county lines drugs outside the house. With a courier turning up and signing off bits of paperwork and carrying in boxes.
So you don't get them mixed up with your county lines work.
Yeah.
Keep those lines set at all times.
Yes, so that's trouble, but I now sit on my laptop working from home for that given afternoon on the phone doing recruitment, and will stick my arm out for my blood pressure to be taken and open my mouth for a thermometer like a complete princess. And it's quite seamless, really.
I have to say they are amazing.
They are,
They
yeah.
really are. They make
And
it
now
so much easier.
My Spanish friend Miguel, who's my nurse, who comes. We talk about brownie recipes, and about
All the important
football
stuff.
team. Yeah.
Any other questions?
What's the optimum age group of people to go on those trials?
So there's no age per se, and Nick mentioned earlier that there is a variation in the age of onset of genetic forms of Alzheimer's disease, and we've got a wide range, ranging from 30s to late 50s. Basically, it depends on the stage at which you are in. So we've got, like I said, primary prevention. So that's decades before your symptoms start. So that's young, very young.
Are you talking 20s?
We're talking above 18. Then you've got the secondary prevention, which is people that are either mild in their symptoms or have no symptoms. And that again is ranging between 30s, 40s, usually, sometimes later. And then we also have those early phase studies that I mentioned, the safety ones. We do, because we really want to be able to offer people things throughout the course of the disease. People that are more affected are eligible to go into those studies. So there's something, basically, sounds naff, but there's something for everyone in terms of options. Yes, exactly.
And the age thing is related to, often, but not always, to the age in your family.
Yeah.
So primary prevention for one family could be when you're in your late 30s, but in another family, it might be in your 20s.
Yeah.
Just because
I would say maybe 20 years prior to the.
that's the sort of thing.
Exactly.
I was asked to
Exactly.
sit around 16 years prior to
Yeah.
what was thought to be my dad's first display symptoms.
Yeah.
So I had to do a bit of sort of.
And it's a pretty imprecise thing.
Well, how does, I mean, I actually went on quite an interesting journey trying to establish
What the age was.
So then you
Yeah.
start asking lots of people, and I actually had some wonderful conversations with his work colleagues, and when people who wouldn't have normally said anything put their hand up and said, oh, actually, I think I did pick something out, wasn't right. So it did again open that sort of forum, but they're not obviously easy questions to ask, especially if it's not something that's an open forum in at home or with family and friends and things.
So, if you go on a drug trial,
Mhm.
and it looks positive, and it sounds like there's lots of positivity at the moment, say you're on it for 5 to 7 years, and it's worked, or there's been signs to suggest it works, at the end of that time, you just, all right then, thanks for carry on with the drug beyond.
I've never, that's an interesting one.
That's such a good question. So most studies, and not all, most studies, once the randomised trial has happened, as with you, there is then an open label extension study, which is you get the drug. That isn't all studies, so you have to be very careful to ask the right questions at the beginning. If you're then in an open label extension study, that is usually a study that rolls over. In other words, it goes on for a period of time, and then often it will continue. If it's really promising, the aim, and again, it's not always, the aim is that they continue to do that until that drug is licensed, but it doesn't always happen. And it's really important. One of the things that we've done is set up a trial support network for people that are thinking about trials, that are on trials, or that have just finished trials, because you're right, there can be the point where you've been on the drug, you hope, and then it stops. Now, if a drug is found to be effective and you've been on it, then there are lots of arguments for you having to be able to continue it via special access, and that there are routes that people can pursue. If a drug hasn't worked and the study's negative, obviously you don't want to be on it anyway. With most, what would happen is if a drug doesn't work or the results aren't conclusive, once it's washed out of your system, you can go into any other trial. So it's not your one chance only. There are lots of things that you can do. And that's one of the things that we're really keen on, is making sure people always know what their choices are at all times. Because you can
You
always
might
change.
also have this one, then you might think, oh, I've heard of this one on the horizon.
Yeah.
So then not have that one, I want this one.
Yeah.
Like, and it's, I don't care, it's, I think what's best for me, and, I'm keeping to like help science.
But no, you're right. And you need to make the right choice for you. And you're right that things will change over time. So for example, it hasn't happened, but the drug that's the first disease modifying therapy that makes a little bit of a difference, is licensed in the States, but there have been huge problems about using it. Very few people have had it. Reasons for that we can go into another time. But when it first got this license, there was a huge upheaval in the trials world, because we all thought, well, what do we do? We now got a drug. So everybody understandably is going to want to have that drug and not go into a trial. And that's one of the reasons why this new arm now has amyloid drug as well as tau drug, so that we kind of put that in as we've actually preempted it being a clinical standard. It's not, but we're trying to ease that decision. But say a drug came up that was a gene therapy that was targeted exactly at your gene and you were on a different study, you need to have very careful think about what you wanted to do. And what our job is to help you understand what we know, what we don't know, and what your choices are. And that's what we can do.
Come onto the trial, you're on.
You can always, it's always voluntary. You can always come off anything at any time. You don't even have to give a reason. I'm quite proud of the fact that we've had very few people do that, because I think we keep their choices and information open at all times. But yeah.
Can I just add to that part that it's never crossed my mind. I've never done this because I think I'm going to get a drug that's going to make any difference to how my future looks. And I think that I'm right in saying that I've never been given that. No one's ever said that there's any chance that this is actually going to change sort of the way it's thought that my early onset may start or happen. So like when you were asking that very valid question, I thought, actually, I haven't thought of that, because I'm involved because I want to be involved.
Yeah.
It's not so much because I think I'm getting cured in any way.
Yeah, I mean, I think different people have different
Yeah, definitely.
thoughts, but I think you're absolutely right. We're very careful at the beginning of a study. You may or may not get this drug. This drug may or may not work. And we have to be really clear about that. If we thought it worked, we wouldn't be ethical doing a study in it. So that's why the study's being done, to see if it.
I found you guys were very good at managing expectations. So remember they were the words you used, and that's really containing actually what you had to have.
I think Laura just made a really important point as well, though, which it's lovely to hear you say it. And for you, for control and for doing something and knowing something's being done. But in addition, it's more than about the drug, which is something that one of the other participants said to me when he wrote to us about how it had changed him. The trial, he felt it had helped him deal with the skeletons in his closet. And he said, thank you for everything you've done. It's way more than just the drug. And I think that's actually a very valid point. Would you agree?
Definitely. And since starting this, I now have a 3-year-old niece who is my favourite thing in the world. And now I can put that, I see that, well, there's a very high chance that this might impact her life in some way. And yeah, there's way more positive power than just what is going on with a drug in your body, I think.
That's a nice way of putting it.
And what about if you're pregnant or thinking of it's not a question for me.
It's not. So I know I've been told that that's not an option for me if I'm doing this.
Yeah, that's very clear. And the informed consent form for a trial, so making sure people understand what they're putting themselves in for effectively, is for DIAN 2, it's something like, you've been reading consent recently, it's something like 35 pages long. So
I've read it. It's awful, sorry.
We've gone through it together. So the reason for that is because we have to be so careful that we've gone through all those things. So no, you can't go into a trial if you want to get pregnant during that period of time. If you got pregnant or you were a man who got somebody pregnant, we have to sign all sorts of forms, adverse event forms about it being a pregnancy, and then follow up both them and the child. So it's
soon after being pregnant, if you had a baby, and then
so probably that would be around breastfeeding. So once you've had the baby, then it would be a question of that drug getting into breast milk. We wouldn't know what it would do, so that would be a risk.
How long does it take for the drug to come? If I said tomorrow I'm stopping and because I want to have a baby.
Yeah.
How long does it take for the drug?
Depends on the drug. If you think about the standard washout before we allow somebody to go into another trial, it's actually quite a long time. It's like 6 months-ish. And I don't know the answer, but I would suspect it would give us something like that.
Yeah.
That's because everything that you're hearing here is around the do no harm.
Absolutely. It's be very, very careful.
Will wash out.
Much
Some of
quicker.
them will wash out in days. Some will wash out in weeks.
And in all honesty, we have had people get pregnant on trial, and baby's fine, and there's no problem. But we have to be, everything we do has to be incredibly careful not to cause harm. Do no harm is the most important thing. So we will be way more cautious than a standard clinical drug.
And this do no harm principle, sometimes when I talk to groups like this, people think we've got the balance has gone really wrong. The very first trial I was ever involved with, it was stopped early because 6% of people got some nasty reaction. And I had people say to me, 6%? Why aren't we carrying on? I'll take that risk.
And with cancer, the risks are way higher. So yeah, it's
No. So it's very, very precautionary.
yeah.
Can I just ask more quickly about finding out about your genetic status, whether that was very much linked to being in the trial and it going, maybe the possibility of going to the next stage, or whether it wasn't linked?
I don't know. I think maybe because I was involved in the trial, so I was making it a more present part of my life before knowing my gene status. I think that may have brought me to a point maybe quicker, I don't know, to think, actually, I want to know. I also think in hindsight, I wasn't having the best time for other reasons, and I think I just threw it in the pot and thought, fuck it, I might as well just, sorry. I'm just going to find out. I don't, so I can't 100% answer, but through finding out that I did test positive, it just, without a doubt, sort of confirmed my involvement, along with factors like my niece. Yeah.
Are all the trials the same that you can't get pregnant, or is it just this trial?
All times.
All time?
Because we don't know the effects of these drugs, and clearly what you don't want to do is cause a problem with the baby. So it's there are many things. There are a lot of constraints and medicines that you might not be able to take, making sure that you're using adequate contraception, making sure that you get to your visits, etc. So a trial isn't for everybody. It is a significant commitment, but what we do is try and make it as positive an experience and as based around you as we can. But there are certain things we can't do.
And who do you talk to, clinical departments, about the trials and the up and coming ones for advice and, just general talking?
If you want to know about a trial,
Yes, if somebody wants to know.
if they want to know, so me is easy enough. Certainly I'm always happy to talk to anybody about any of the trials that we talked about and other ones. You can get general information about research that happens from our recruitment team, but I think some of these things are quite complicated, and so Nick and I would always be very happy to talk about anything.
Sorry, again, what's the average length of each trial?
So for the ones I've been talking about, they're long, but there are different studies that are of different lengths. So the early phase studies, like the joint ESI one, is the initial phase was just 3 doses, and then the second phase is 18 months. Some studies are as short as 6 months, depends on what they're trying to find in terms of the safety for the early studies. Ones where we're trying to find that a drug has an effect cognitively on your memory or on other factors have to be long, because we're looking at people early in the course of the problem. They may have no symptoms. We're trying to find really subtle changes, which will take years to show. So there are different lengths depending on what we're trying to find.
Typically, things where I say they're longer if it's earlier. So the primary prevention ones, just for the reasons that Cath was saying, they have to be longer. You can imagine, you're perfectly well and you got given a drug for a week, and then say, oh yeah, it was positive.
Yeah.
But I was still perfectly well, and I was perfectly well before, so they have to take be longer, but nearer than they can be.
No, that's right.
I was just going to say, I don't remember what I was told about the time frame when I first went on the trial, but I think it was 2 years, and then was extended.
That's
to
right,
4.
exactly right.
And I didn't look at it as I'm doing this for the next 4 years of my life. Now, there's no denying that it is a really important decision that shouldn't be taken lightly, because dropout is not going to aid the process. But I just thought of it as, this is what's being asked of me. I can do this right now, and I think once you're involved, it
becomes part of life rather than a burden for people where it's managed right. Sometimes it becomes too much for somebody and they can stop.
But there's no denying that talking about years or something sounds really daunting. Like, if someone asked me what I was doing in 5 weeks, I don't have any idea. So I think just not viewing it as, again, it's a very important decision, but just thinking of it as something you're signing up to for years, it doesn't feel like that.
It's good to know.
Are the new clinical trials in combination with the current medications that one's taking?
Yes, very good question. Yes, they are. So the symptomatic medications, the medications that are available right now, whether it's donepezil or galantamine, rivastigmine, memantine, you stay on those if you're on them. All that is asked is that you're stable on them. In other words, that you've had the same dose for 3 months before you go into a study. So yes, those medicines stay the same. You don't have to come off them. Does that answer the question?
Probably should if there are
No more questions. I'm worried you'll get denied lunch. So thank you very much, Laura.
Can I just say one more thing before, sorry, one more thing. Laura incredibly generously said, like me, like her, sometimes questions occur after you've been sat in the room. So if anybody has questions they want to ask Laura, she said to me that she's happy to answer those, which is really kind. Thank you very much. And thank you very much, because that was fantastic. Thanks.
That was an amazing session. Great to have such expertise. So now lunch, somebody will need to tell me what I meant to say.
So lunch will be served across the room.
Where you had
our
coffee.
lunch boxes.
Where we had coffee.
Where we had coffee, yes, coffee
Yeah.
with your lunch boxes. I would just go and see the lunch guy on the desk and make sure the car was open. And I'll speak to God to make sure it's ready.
Those of you on this, you can see the next slide.
Oh, yeah, no, it doesn't matter.
I didn't want to mess up what was, the windows were 5 windows.
It's fine. The funny thing is I usually talk my way in between the lines. It's quite funny. I have done it.
Oh, that old school.
Yeah. Go back old school, exactly. Thank you.
So we don't have extra. We don't have slides inside there.
Yeah. I remember that.
Yeah. How are you? But I have to say, I don't understand. I don't know if we want to
We're not stopping. They'll come. Yeah, we are stopping.
No, for anybody watching at home, I don't know if you're out there, but we're just going to pause the stream for lunch and then we'll be back. Thank you for joining
Can they see?
Yes, exchange.
If you're there.
Okay, well, sorry to tear people away from sunshine and lunch and more importantly, from conversations. The next little session is a sort of speedy section on a couple of research projects, just that may be of interest to people. But before I do that, as you go through the day, really interested in what people think about sessions that are good, bad, didn't work, would have liked more time for, that spent too long. And just talk to any of the staff about that. And I want to float an idea, which is various people here in this room had input into the sort of things that we would talk about. And there are some things I presume people always want to hear about. People usually want to hear about trials, but there are different things there. So if there was interest in one or two people, members of the group, saying, sending in an email or speaking to somebody about saying that they would like, with other people, to run a session, an hour in a future meeting, whatever you want, but suggest that, and we can, if it seems totally bonkers, we'd say maybe in a few years. If it's not, we'd say, great, we'll help you do it, and it's over to you. So this is the fAD support group's meeting, and it should be that in terms of ownership as well as participation. So open for all suggestions. And then we are, I think many people know, Phil, who was clinical fellow on the study and is now back as a consultant neurologist and has his own fellowship, which is great. They're very, very hard to get. And Phil, you want to talk to people about some of what you're going to be doing. Is that right?
That's right, yeah. Good small part of it. So yeah, thanks, Nick, and it's great to be here today and to be able to speak briefly about an exciting new study that we have planned. So, as Nick mentioned, I was previously at the DRC a few years ago and involved in the coordination of the day-to-day running of the fAD study at that time, and that was really, a great time. I met many of the people here today. Visited many people's homes, was made to feel very welcome as part of the research I was doing, and it was a great time from the point of view of the research and the science that I was able to do, but also meeting the families and getting to know all the individual stories. And after a few years away, I'm now back, as Nick mentioned, and
You want to select? Okay, it's not
It's a TV.
Where's the?
It's a TV, it's not.
Okay. Select. Okay. They're censoring you. It's probably a rival support group.
So I'm now back, and I am going to be doing some new research at the DRC, and I'm very lucky to still be involved in the fAD study. And from a research perspective, and so this isn't drug trials, but this is just trying to understand the illness and what changes occur. And I'm very interested, I'm not the only one, in trying to understand what changes very early in the brain, in fAD, and how we can detect that and track that, so that we can understand things better and intervene earlier, and to hopefully have a better chance of developing new treatments. And previously I looked at that using MRI scanning, blood tests, developing new memory tests. And this was just an example of one of the MRI studies we did, trying to identify the pattern of early changes in the brain. And MRI scans really can be very valuable because they tell us not only when things change, but also whereabouts things change in the brain, which we can't get with a blood test, for example. And they're also very safe. They use magnets rather than radiation, so we can have as many of them as we like. But in terms of the MRI scans that we use and the actual scanners, they haven't changed much over the last 20 years or so. But just over the last few years, a more recent development has been the advent of what we call ultra-high field MRI scanning, or 7 Tesla MRI scanning, which essentially just refers to the strength of the magnet. And this essentially uses far stronger magnets to generate much more detailed pictures of the brain than what we could have done previously. So we divide the brain up into tiny little cubes, and using one of these newer scanners, we can make those cubes about 8 times smaller in volume than they would have been before. So we can begin to get pictures which approach the detail that we might have only seen before by looking down a microscope at the brain, so-called MR histology. With an example here of an MRI scan on the left-hand side, and the corresponding real brain on the right, to show the level of detail we can see. Now, one of the drawbacks of this type of scanning is that it's very expensive, and there are very few scanners around in the UK. But fortunately, just a couple of years ago, we had our own 70 MRI scanner delivered, which was not the most straightforward of things. To Queen Square, and it's actually located directly next door to the DRC in the Welcome Centre of Human Neuroimaging. Many of you will recognise the street as being the street directly outside the DRC. What's even more exciting is, as of very recently, we now have funding to use this scanner within people from fAD families to try and help us answer questions that we couldn't have answered before. Although it uses a much more powerful magnet, so previously all the scanners at Queen Square and used in most hospitals around the country don't go above what we call 3 Tesla, which is essentially just the strength of the magnet. This is a 7 Tesla MRI scanner, but the scanner itself looks very similar to any other scanner, which I'm sure people who've had them would recognise here. And the experience of being in the scanner is very similar. They're not greatly different from what we have with our other scanners. But hopefully they offer a lot of advantages, and this was a picture of the first ever volunteer being scanned on the new scanner at Queen Square. What's also exciting, without going into too much detail, mainly because I don't understand it myself, is that colleagues at the Wellcome Centre of Human Neuroimaging have developed new approaches to how we extract new information from these very high resolution scans. So by combining different pictures together, we can look at specific kind of chemical components within the brain, and hopefully that can help us understand why two people who might have similar amyloid in the brain seem to have different illnesses and have different symptoms and different rates of changes and other things. So they're obviously missing links that we don't fully understand at the moment, and this will hopefully help us probe into some of those using what we call quantitative multiparametric mapping. So combining that with the new scanner, we hope will be very powerful. So now just to finish, to say what exactly are we planning to do at Queen Square with this new scanner. So we are planning initially to scan 25 participants, and these are people who, and many people will be familiar with the fAD study that we have, the observational study that already exists. This will be people who are already in that study, and all we'll be asking them to do is essentially come for 2 scans, one at the beginning and one 2 years later, so 24 months apart, and that's really all that is required above and beyond normal participation in the study. So we don't need to do any extra blood tests or any extra memory tests, because those are already performed as part of the larger study. But hopefully by doing 2 relatively short scans, we can gain a lot of additional information to add to our current understanding. And we're aiming to start later this summer, all things being well. So, and if anyone has any questions, obviously people can ask today directly, but also feel free to email me directly about this or about any other kind of research related questions. My email address is there. And that is really everything I wanted to say today. And thank you very much, and hopefully look forward to speaking to people and working with people.
And irrespective of research, I'm embarrassed Phil by saying how nice it is to have him back at the DRC. And I do think we're going to do Q&A after Selina speaks, but please do catch any of us about things that that are raised at any of the sessions. That's all fine. Okay, we're going to take questions at the end if that's all right, Phil. Selina. So it's a great pleasure to introduce Selina Wray. Selina has actually not brought brains in a dish today, I don't think.
Not today.
But that is what she's going to talk about. I don't know quite what happened to my brain in the dish, but maybe it didn't do so well.
Maybe it's better I don't tell you.
You'll understand after she's done.
Oh, thanks, Nick, and yeah, I'm so pleased to be invited back to this meeting again. I think this is the 3rd annual seminar that I've spoken at, and it's always really a pleasure to share with you some of our research that might be a bit different to the other things that you've heard about. I'm very much a lab-based scientist. As Nick said, I work with brains in a dish, or to put that a different way, cells that we can grow in culture, to really try and understand a bit about what's happening in the cells when people develop Alzheimer's disease. So some of you who I've known for a while will have seen some of these slides before, but I know that some of you will be new, so I've hopefully got enough background so you can all follow along. So really, I always put this slide in my talks just to help orientate everyone of where I am in the research process. So I am a molecular neuroscientist, which is a fancy way of saying I try to understand the small stuff. So specifically, I'm working on DNA and proteins, which are the very smallest components of what make our cells. So for example, neurons, which are the main cells of our brain, and obviously all of our organs come together to make us. And the reason I show this schematic is because I think it makes it, it helps us to appreciate that if something goes wrong at this very small level, the impact of that can be felt at every stage of increasing complexity. And that's really interesting to me as a scientist, because it means that if we understand what's happening here, this is where we really want to intervene when we design therapies. So if we stop things going wrong here, it should stop things going wrong at every increasing stage of complexity. But of course, we have a real challenge when we try to do that, especially when it's diseases that affect the human brain, because the human brain is not very accessible to us during life. So although we can kind of look at the changes that are happening in the course of somebody's disease, it's very hard for us to put together a sequence of events. So if we look at the kind of brain of somebody who has had Alzheimer's and donated their tissue to research, we can see a whole number of things that have happened within that brain. But how do we know what's happened first? It's a bit like turning up at a crime scene where you can see the damage that's been done, but you've kind of got to use your forensic powers to try and put things into order. And so what we try to do is we gain some insight through what we understand about genetics, and we try to use that to build models. So genetics tells us a little bit about the order of events. What we know from the study of rare genetic forms of Alzheimer's disease is that there are changes in particular protein that is associated with the development of plaques in the brain, and this is happening first before the subsequent damage. And so what that tells us is hopefully if we can stop that plaque pathology from happening, maybe that could be one way that we could stop the rest of the cascade from taking place. And so what we try to do is to model this cascade in the lab. As I've mentioned, modeling diseases that affect the human brain can be quite difficult. And a lot of models which are widely used in research, such as mouse models, for example, are really informative, but of course the brain of a mouse is very different to the brain of a human. Some, not all. But in terms of size, in terms of complexity, in terms of lifespan, there are a lot of key differences there. And so what we need to do is find a way that we can fit another piece in this jigsaw to try and complete our understanding. And to do that, we are using stem cells. And we're using a particular type of stem cells, which we can generate from people who contribute and participate in our research studies. So specifically, what we ask is for people who are participating in research and may have a gene associated with a disease that we're interested in, to donate a small piece of skin from their upper arm. We can use that to generate their skin cells. They're very easy to grow in the lab. Our skin is constantly renewing itself. And what we're able to do using techniques that have been available to us in the last sort of 10 years is change those skin cells into stem cells. Now, stem cells are a blank slate. They're the master cell of our body, and that means they have the potential to become any cell type that we're interested in, including brain cells. So we can take a piece of someone's skin and we can go through this process and turn those skin cells into brain cells. And that's why we call them brains in a dish, because we have brain cells that we can grow in the laboratory, and we can compare the cells from people with and without particular genes or particular conditions that we're interested in to understand why they behave differently. And what are the, again, reinforcing what Phil said in his talk, understanding the very, very earliest things to change in those cells. And so I thought I would show you, I haven't brought them with me, but I thought I'd show you some pictures of what they would look like when we grow them in the lab. Our brain cells are very, very beautiful. You can see here these green processes are what we call the axons. And it's these processes that allow the cells in our brain to communicate with each other. And it's that communication that we now know starts to break down a little bit when somebody develops the beginning stages of Alzheimer's disease. And we can also eavesdrop on those cell cultures. So I'm not just telling you this happens. If this works. Oh, wait, it does if I click the right button. There we go. So this is us eavesdropping on the cells in the lab talking to each other. So what you can see, every time one of those cells flashes, it's sending a signal to a cell that it's connected to. And so we can start to mimic really how our brains are working in a very, very simplified form in our laboratory, and try to understand the changes that are happening in Alzheimer's disease. And this is, I'm almost getting to my last slide, but what you can see here is we have a range of cells from different research participants and a range of cells from people who are unaffected by dementia. And what we see is we start to see disease signatures starting to emerge within the cell culture lab. And this is really powerful for us because it means we now have a system we can use to understand why those changes matter to the cells, but also we can look for ways to stop these changes from happening. And this is something that we are starting to do now. I think at the last meeting I spoke about, Nick said, oh, you know, we're talking to a few companies about starting this work. We've now started it, and we're looking for ways, as you can see here, that we can reduce the levels of these Alzheimer's disease associated proteins. Now, I have to be really clear that this is on cells that are stuck to a layer of plastic in a dish that are grown in a lab. It's the very first step in what would be a very long process. But at least now it's letting us close the gap, I think. As a cell biologist, we always feel a little bit removed from some of the other things that you've heard about today, from the brain imaging, from blood tests, from things like that. We're now taking a step closer and kind of understanding the disease at the cellular level, using cells that have been really kindly donated by participants. And so I would finish by thanking the people in the lab who've done work. Emily is here. She just joined the lab a few months ago to do a PhD with us. And then Charlie and Rebecca are also really involved in this project. So yeah, thank you for having me back and thank you for listening. I'm really happy to take questions.
I'll just be careful with your glass now.
Sorry.
So just while we put some chairs up,
I thought it was me. I thought I disconnected something.
These things they're like Star Trek. I mean, it is amazing that you can take a piece of skin, tell it to forget all its development, go back to the blank slate, blank piece of paper, and then tell it to become a brain cell. And that is just, I mean, Selina describes it beautifully, and as you know, like it's all really easy and simple, but it is pretty amazing. It is pretty amazing. You know, massive progress has been made in skin diseases because people could just take a biopsy of the skin and look at what was wrong. We couldn't do that with the brain. We couldn't follow it. This is just amazing that we can do that. And the last bit that Selina was talking about, which Emily at the back is helping and working on, is this knocking out the gene. And, you know, that looked rather prosaic or simple, that, you know, that little plot where Selina mentioned as though sort of just in passing, or we've not, there was a sort of bit of a gap in that little thing there. That's knocking down a protein that causes Alzheimer's disease. Knocking it out. I mean, it's amazing. Of course, as Selina says, you know, getting stuff in a dish where you could just, you know, pour stuff on, it's pretty easy. It's not quite the same as getting a medicine into the brain. We are learning how to do that now. We're learning how to do that through, you know, infusions into the cerebrospinal fluid, which is a bit like a lumbar puncture, but also we're finding clever ways in which we can give something just as an injection into a vein and then trick the brain into taking it into the brain, which is all clever stuff. And you know, the stuff that Phil is doing with 7T, of course, you don't want to be metal when you're going in there because they would never get you out again. Isn't it something like 60,000 times the Earth's magnetic field? So it's quite strong. So yeah, they don't leave any paper clips lying around because they never get them out of the machine.
No, yeah.
So anyway, with that introduction, I'd like to turn it open to questions to Phil and Selina have been talking about, or anything about research, or things that have gone before. Any questions, anybody?
I'm just really interested in that image of the cells in the petri dish actually sort of firing up. How did you get them to do that?
They learned.
Talk nicely.
They learned to do it themselves. So the way that we make these models is we try to understand how the brain develops, so during pregnancy, and we try to mimic that process. And if we give them we give them certain kind of cues or signals that we call growth factors, not dissimilar to gardening or something, I suppose, that tells them to become a certain cell type. And then the rest of it, once they've been given that sort of initial push, they just know how to do that. And so they play out a program of events, which is very similar. What we're essentially mimicking is how the brain develops in the first trimester of pregnancy. And so at the end of that process, they just know that they need to connect to each other, which is nice. It makes our job easy because it's spontaneous, so we can just kind of eavesdrop on them doing it. But yeah, the fact that they, as Nick said, I still find it quite remarkable that we give them this initial cue and then they just do the rest and they know how to do it. And I find that quite remarkable.
It's amazing. It's a great question again, and I do still, clearly I'm easily susceptible and persuadable, but it does make the hair on the back of my arm stand on end. Just amazing that this can happen. And of course, what's underlying all this, sort of, they do it naturally, is because of that, which is why you're all here, genetics. It carries the genetic information to build a brain. And it also carries, in certain of the cell types, the genetic spelling error in that huge recipe. And that one spelling error is what makes a protein go wrong. And Selina can pick up that happening in a way that you couldn't. You couldn't be sticking, boring holes into the, well, very few people, ethics committees would allow you to dig a hole in the brain, take a sample, and we'll see you next week and we'll do another one. You can watch it. Other.
Do you need to know your gene status to participate?
I don't know the answer to that. I don't think so. I mean, all of the samples when they come to me are anonymised anyway. So I don't know if the individual who is given those samples knows their status or not. Nick is nodding at me, so I can say the right thing.
Yeah.
Okay.
So you don't need to, but what the early part of research is you'll need to know the genetic status, but you don't need to know that. And then there's no way, and this is true for lots of our research, stuff that Emily's done on fluids or the statisticians working with the scans, is the genetic information is linked up with your scan or your brain in a dish, but it's all anonymized, so it could never get back. Unless Selina looks at it and says, oh, this looks a little bit like Rachel. That would be hard.
I do, sorry, I have a question for Phil. It's quite a personal question, so it won't probably relate to anybody else here, but I have already spoken to, I have messed with my face through surgery. I spoke to my consultant and said, is it MRI safe? And they said, yes. I don't know if the MRI scan that you guys have that is that powerful, if she knows that's what I was talking about. Would that be safe?
Yeah, so for a conventional scanner, or the other scanners we have at Queen Square, it shouldn't be a problem. It's said to be MR safe for kind of various reasons, because this new scanner is so new and the amount of experience with it is slightly less. We tend to be, and because it's purely for research, we tend to be quite on the kind of cautious end. So it may be that it's difficult to do it specifically for that scanner, but it shouldn't be a problem for the other research scans that we do.
Yeah, so it's a bit like the trials. If you need that if you need the scan for your clinical care, there'll be a much lower threshold for allowing it. But if it's for research, the same for going into a clinical trial, if you've got a sort of anything that would possibly be a question mark about risk, the thought would be being on, because it's not essential.
Okay.
So that's where it is. But the new scans, I remember when the first 3T came in, I mean, it was a tremendous palaver. You had to, had you ever had an operation? Well, I think so. Oh, well, then you can't have the scan, just in case somebody puts a metal in you. And then over time, it just gets, people get experience. They know that actually, and everybody really worries about, so I've been MRI researchers where I started, and I've had at least a dozen scans. And I'm not bad normal. Well, no, I don't know comment. But people do sometimes worry about high risk, and the MRI scans are really safe. There've been a couple of deaths, only because people, not in the UK, took an oxygen cylinder into the scanning room. So you suddenly turn an oxygen cylinder into a high-speed missile. And you thought, is a big sign saying no metal in this room? You know. Anyway, so you can't ever rule anything out. So if you're in the scan, you see somebody coming in with an oxygen cylinder, say, hold on a moment. No, it's not. I think there's been, there's been a couple of injuries worldwide. Any other questions?
I just wanted to talk.
Yeah, of course.
The genetic testing and gene silencing, it's all looking at silencing the gene that makes the amyloid and tau protein keep reducing. What about the gene silencing that stops maybe our specific genes?
It's a great question. Do you want to have a stab at that, and I'll come in behind it? It's I mean, it's a great question, Jackie, because it's a very active debate about. Well, no, I'll let Selina before I chip in.
Let's see if we both say the same thing. So for me, the reason that we are interested in just silencing the gene rather than specific forms of it is because if that approach works, it means that it's one drug that could be used for everyone. There are certainly in other diseases approaches looking at silencing specific spelling errors or specific changes. Scientifically, that is an approach that I think could work well. On a practical level, the challenge is it means each different spelling error needs a different drug. So in terms of actually passing the regulatory process for getting those into clinic, it becomes a much bigger challenge. So that's the reason why we're taking almost a two-pronged approach of let's try gene silencing first, just switching the gene off. If that works, that one drug works for everyone. If that doesn't work, the next step could then be to look for specific drugs to specific changes.
It's a great question, Jackie. I'm going to say the same thing as you. Yeah. So to give you, but I think the future may well be that. If knocking down one of these proteins like amyloid works with this gene, and that works for all genetic errors, whatever they are, wherever they are in the gene, great. That's so much easier. But there's been a rare genetic illness, nothing to do with Alzheimer's disease, where I think there were two members, one family with two people, and they designed to target the genetic mutation in that family and treated them. And
how long did that take?
Yeah, it didn't even go through. It was called what's really rare, what's called an N of 1 trial. Normally, the trials that Cath was talking about are hundreds of people, which I'll come back to in a moment. Why you're all so important. But for this, they made an exception. It was a rare disease. There could never be enough people. So they got approval to do a trial. What N is 1 is, the trial could go ahead where there was one person in the trial. That would be amazing. And that wouldn't have happened before. So that is, I think that is some of the way of the future that there will be. But all the things that Selina is doing will give us a clue as to whether or not this non-specific silencing of the whole amyloid thing works for many mutations, because that's why we need lots of skin samples from different mutations, and because we want to see whether it works on different things, different mutations.
So just on it, so it's interesting, in cancer there's quite a lot of treatments now that target specific genes.
Personalised medicine, exactly
technology,
that.
is it?
It's
Okay.
exactly that. Right. And that's been a revolution in the last 5-10 years. You work out. Sarah.
Do you want skin at the moment?
Coffee? You didn't bring your kids? No.
Not today.
But yes.
It's quite easy to.
It's really easy. Yeah. It's really easy.
Yeah, it's, I mean, I didn't talk much about it. I mean, Phil collected some of the samples that we worked with, as did Natalie and Helen. We take a skin punch biopsy, so it's almost, we started off with ones that were about the size of a rubber on top of a pencil, but as we've got better at it, I think they're about half as I've got better at it, not these guys, I mean, as we've learned how to treat the samples downstream and taken, I think it's about half the size of that now, isn't it?
Yeah, it's just like the nib at the end of a pen almost. And
Yeah.
just a couple of stereoscopes.
And not, yeah, exactly, not local anaesthetic, right? Or even not that anymore, I don't know.
Depends how
yeah.
brave you're feeling.
Yeah.
But what Selina's not saying is taking the skin is very quick, and the original ones were the single stitch in, or not even that. Now, not much less than that. But Selina and her team come in on Saturday and Sundays, travel in because they got to. Do you remember those? What were those things called? You had to feed.
Tamagotchi.
So they have to go in on Saturdays and Sundays to feed, I think, talk to the cells, so they feel loved, so they develop. And so it's a huge amount of work just doing one cell line. So that's where it's not, in many things, in familial Alzheimer's research, it's a lack of participants. In some cases, it's actually just having enough resource and people to do it. I mean, if you all donated skin cells today,
Please don't.
Selina's life would be totally ruined. Just not possible. There's not enough lab space. But so that's one of the reasons my bugbear earlier, or the things that make me furious, is that there are people who would like to do skin cells, and if we had more resource, more money for research, we could do more and go faster.
Joking aside as well, one relevant point to add is that we can actually store the cells as well. So we, when we've had donations, we cultured the skin cells, and we can then almost put them into store them in liquid nitrogen. So it's essentially a deep freeze, and it's a little bit like putting them in suspended animation, so they can stay there forever in theory. And then at a time when we think, right, we need to work with these particular cells, we go and get them out in the freezer, we thaw them, and they kind of revive and grow.
And we share the cells for appropriate researchers around the world, so it's not like it's helping others as well. Anything else on that I was going to say? Yeah, Helen.
I was just thinking, it sounds like we may have a few willing volunteers in the room here, not hoping to assume too much, but if anyone is interested in finding out any more about donating a skin sample or potentially Phil's study, I'd be happy to field any queries and support that. And, yeah, thank you.
Do you need normal ones? I'm not saying normal.
Normal ones. Normal for where?
Yeah, we do everything we do is matched with people who are unaffected. And typically, I think those matched cases come from siblings or partners and people like that. So yeah, people who are unaffected or
we definitely have research where we want people who are just have to be normal controls, whether it's from scans or skin biopsies or blood samples. There's always a need for that. So you can be signed up as.
Does that? This is me being fickle, but. So to
Sure.
create it, if Mike had been able, he then became too ill just before he was going to donate it, would that have created what is wrong, his genetic imbalance, and that little piece of skin would have created what was in his brain?
Exactly, because
so you're seeing
the alteration is in the DNA, which is the same in every single cell type. What we don't understand in Alzheimer's disease is why does that change in the DNA specifically affect the brain? So why is it a brain disease rather than a liver disease or a skin disease? And so that's why we go through this process. So we're making exactly the cell type that are affected. And yeah, we see these signatures that resemble what would have been happening in the brain.
But the short answer is yes. As part of I've heard lots of people talk about how within families there are people who want to know everything, who come to support groups, who take part in research, and there'll be other people who don't want to know anything. And so one of the things about or their circumstances such they can't. So one of the things is that things like blood samples and skin samples mean that people who would be less keen on taking part in research, coming to London, having a scan or whatever, even though that's really important, we can do with, the plan had been before the pandemic, we do home visits. So I would like you all to be ambassadors for the research. And that's about talking to that cousin who might not want to go down to London, but might go part of a trial, because just last bit back, Cath talked, Cath and Laura talked wonderfully about trials. When I first started, everybody with a familial AD mutation was excluded from trials because they didn't have normal Alzheimer's. They were too young, it couldn't be normal. And I remember sort of, kind of in fury talking to pharmaceutical companies. These are the most motivated people you will find in the world. Oh no, but they can't have Alzheimer's disease because they're only 50. Our trial is for people above 55. And what's changed that has been actually people like you, the advocacy of saying, yeah, we want trials, but also there are enough people. You can't do a clinical trial on 20 people. You can do the first things, you can't go through them. And so actually we desperately need, that's why there's so many sites. We need you to persuade cousins, aunties, and often it happens one advocate in the family helps, and one person is a champion. That's what we need you to do.
I was going to say this in a different way for something else, but it's like with the MRI scans and other testing, we try and do it on people before they get symptoms and when they're first diagnosed. But then I like to bring my mum for a day out. So she was diagnosed 2014. She's not mobile. She hasn't had any contact with a consultant for a few years. But like she's probably about as advanced as you can get without being like. Would it be any use to see her brain where it like just before death?
Phil, do you want to have a stab at that?
I mean, I think it's
like, yeah, it's not like because I know she'd be happy for any research. Her brain will be donated, but we do early testing. But
yes.
Makes testing help or not?
So I suppose different research is aimed at understanding different aspects and the things, for example, like this Selina's research, that it doesn't really matter what stage the person is at the time they give the biopsy. But I think whilst we're interested in intervening and understanding the changes very early, we have to know what their kind of natural trajectory is and where people are, where the illness is going to. So I think being able to map things all the way along, even if we think that intervening at the early stage is probably the most helpful stage, and to get the comprehensive understanding of the whole illness from beginning to end, I think is a useful thing to do. Obviously, certain tests can be difficult for certain people, so staying very still in an MRI scanner, for example, can become more problematic for some people than others. We have to take those things into account as well. But I don't think we'd want ever necessarily exclude someone based on where they are in the illness.
Absolutely. And there are some things that most people at whatever stage can tolerate a blood sample, and that can be valuable at any stage. A 70 scan, probably not. But also we need to understand, and Natalie's spoken before about the research which is going, which is trying to understand stages and what changes happen at different, because that will inform other people. And it's, doesn't have the sort of will change the course of disease like the cell work that Selina's doing, but actually that's really important for people to understand. We're very poor at being able to. I see people in clinic and they say, well, can you tell me what the future holds? I'll give you a bit of an average, but it's poor. So understand that. So there's a short.
I just think it's interesting as much as anything to see how well the body can self-function. Because when you show the pictures of a normal brain and advanced brain, my mum was diagnosed too late, but her brain already looked like the advanced brain 5-6 years longer than that ago. So I think it's fascinating. On a slightly different note, when we say we're desperate for resources,
Like, I don't understand hashtag, but I know it's trending on places. Who do we all hashtag and to get trending on places to annoy? Because I've tried my MP and telling
Good for you.
But
There is a campaign at the moment from Alzheimer's Research UK who are trying to establish this dementia medicines task force. So they have got Kate Bingham, who led the vaccine task force for COVID, to try and lobby the government a little bit to establish something similar for dementia. So they are running. It is more emailing your MP, I'm afraid, but there is kind of they've got.
There are things you can do, but whether you for fundraising, it'd be closer to home. The National Brain Appeal raises money for the support groups and for the research, so that would be fantastic. But also, I think within this group, people always say the reason why there was a cure for AIDS was because there were very articulate HIV positive and HIV positive partners who went and lobbied the US Congress. It was as simple as that.
So even like I'm registered with the Brain Club, I don't see much of it come to my door, so I'm actually climbing up the 3 peaks in Yorkshire in June for the Alzheimer's Society.
Oh, don't tell me that.
I'd rather do it for
I
us.
should.
So I
Yeah,
don't-
do. Okay, so definitely. So
I'll change it.
at the back.
Yeah.
Do you want to stand up and introduce yourself?
My birthday money goes to you when my birthday money on Facebook goes to the Brain Club. I try to spread it around. Yeah.
So please do, just do, have you said hello and said your name?
Yeah, so Stephanie.
Steph. Yeah, so we'll help you with various things.
If I'm not hearing about it, and I try and put myself everywhere, so it's like, who am I?
Okay, so we need to do better. We need to be better. You're absolutely right, Chrissy. We need to get better. We need to get out there. We need to be more powerful advocates, whether it's with the MP or our cousin or whatever. So we need to do that. Now, we probably should move on. So thank you both. Thank you for taking the questions. Thank you for the great questions. So I think we've got Nikki and Seb and Ella.
Thank you very much. Thanks, Nick. Lovely to see you all. So I'm Seb, if I've not had the pleasure of meeting you before. I'm one of the psychologists at the Dementia Research Centre and at Wray Dementia Support. And Nikki and I just wanted to give you a brief update about Wray Dementia Support, which, as some of you will know, is the sort of umbrella overarching service by which we try and provide practical and emotional support to anyone living with any kind of rare form of dementia, not just fAD, but 7 different dementias now across the UK and further afield. And we put a few numbers on the screen, not because numbers are important, but much more because you're important, and we want you to know that this group, which started just as a sort of an isolated group for people living with fAD, excuse me, is now part of something that's much bigger and that's growing, and where we're trying to bring together different communities living with different rarer forms of dementia. Some of your needs will be individual and specific to your diagnosis, or to you, more importantly, to you as a person, but others will be shared across communities. So, for example, we have a familial group for people living at risk of frontotemporal dementia. And for those of you who are perhaps caring for a loved one, we have a number of services that we offer that try and share experiences and good ideas and strategies across, as well as promoting education and research. So just briefly, before I hand over to Nikki to say a little bit about the direct support team, which is something which has started since the advent of this group, just to say that there's now over 4,000 people who are members of Rare Dementia Support. About 4/5 of those are people with a personal lived experience of rare dementia, and about 20% are professionals who are trying to constantly engage to raise awareness of these conditions. And membership went up hugely over the pandemic. We used to only have these meetings where people would come in person, but now we've got a whole array of small and large, regular and irregular online meetings, so that people can come to us not just geographically from wherever they are, but also really importantly at whatever stage of dementia they're living with. We used to see people around the time of diagnosis and for a few years, and then some people couldn't travel to be with us anymore. And so the online meetings have been a great way of reaching out and keeping people connected. And just a couple of other things. The website, which needs much improvement, if you've been on it recently, we're on that, but it has at least been successful in sharing information, much of which has come from you guys as you've helped to shape fact sheets and share your experiences of living at risk of or with one of these conditions, far and wide across the country to many different lands and continents. And also people like Sophie, for example, took part in our Many Faces of Dementia MOOCs, and now 80,000 people have learnt something about several of the different rarer types of dementia that they didn't know before. So this is also really a platform for you guys where you want to, if it's right for you, to share your experiences and actually change people's minds and increase people's awareness about dementia, not just being about old people, not just being about memory, and having many different guises. Nikki, do you want to say this about the direct support team?
Yeah, I will do. I will actually beg to differ about numbers aren't important, because numbers are really, really important.
They're
The
not
more
only
numbers we get, the better chance that I get with some extra funding. So numbers are really, really important to me. The direct support team, so I started with RDS probably about 4 years ago now. I'd worked with them in partnership with my previous job, and I'd spent a lot of time working in clinics. So Seb sort of brought me in to start up some support. And then, after a while, the pandemic exploded, and now we've got a really good team of advisors. Some of them are doing their PhD, some of them are animal nurse. They've got social services background, they've got research background. So there's a whole load of clinical and practical skill set that's there. We spend a lot of time supporting our members. And I'll go back to what Nick was talking about with the myths earlier. I spend quite a lot of time talking to people that snake oil is not going to do you any good at all, and very bizarre sort of questions that we get on that. But what we do is really help people to get their diagnosis. We have people come to us with worries about loved ones having symptoms, worried about family history, and nobody's put 2 and 2 together and come out with 4. We help people understand their diagnosis and plan for their futures, and we help people right up to the end when there's lots of changes happening and transitioning. So I think a lot of you have been here with continuing healthcare funding nightmares. Well, hopefully we've been a help with that as well. We really feel the importance of joining people together. So it has been difficult in the pandemic that we've not been able to meet, but we've really sort of brought people together on online support groups, and we've got monthly support groups now for many of the carers groups. And we're doing much more work sort of joining different carers together, which come from maybe some of the different groups, but they've got a lot more things in common than they anticipated. And Mike, you were really great at our last carers webinar to share your story, which went down an absolute storm. We normally have about 60 people watching them, and we have 140 people. So I think you're in competition with Seb for our next pin-up boy, But no, there's a lot of support that's needed, and a lot of sort of questions. I always say to Seb, we're small but big. We're just a very small team. We're not like the Alzheimer Society that has people everywhere. We've got 4,000 members all over the world, and we are doing Zooms with people in Australia and Canada. So it's very widespread, but it's very sort of very niche what we do, but we really hope it does sort of help people, and we really sort of encourage you in a slightly different cohort to some of our other groups, but what we could do to help.
Great, thank you, Nikki. Just a couple of other things to flag up, and I hope a couple of encouragements. One is a huge thanks to anyone who's taken part already in the Rare Dementia Support Impact Study, of which the Poetry is a part. As Phil said, there are different types of research for different situations, and the impact study is open to anybody in whatever role or situation you're in. So if you'd like to find out more about that, come and see me afterwards. A big thanks and shout out to people like Roberta, who's at the back of the room, who coordinates all of our regional support groups, of which there are usually between 25 and 30 across the country, in which we're always trying to grow new opportunities for people to meet others who are not only connected by their diagnosis or the situation they find themselves in, but also the community in which they live. And there were over 400 meetings across the whole of the RDS service last year. Nikki mentioned briefly about online groups. Helen and Emma started a fantastic online fAD group, in between these annual meetings, which I think some of you have had the chance to be part of, and Natalie and Nikki and others have been part of that too. So we'd talked in previous years. I feel like we'd talked for a few years when we were meeting physically, or wouldn't it be good to meet up more often? And so I hope that those online meetings are one of the opportunities to have a bit more regular contact and to deepen your friendships with others within this room and outside it. A couple of other quick encouragements before I hand over to Nick, maybe to say a word or two about our plans for the centre. We're really excited that recently what's been going on at RDS is now being modelled in Canada, so they've got some funding to set up an equivalent rare dementia support service there. So that's an excitement for us about how people living in many other countries outside the UK can have the opportunity to connect in the way that you guys do. And Natalie will be saying a bit more about international links in a moment. We're trying to partner with other dementia charities in the sense, just to reassure you that we're not trying to recreate the wheel. We're trying to stick to our bit, which is being specialists in rare dementia support. They're trying to join with organisations like Alzheimer Society and trying to sort of nuance their campaigns and their outreach. And also very conscious that at the moment only about 5% of rare dementia support members, and I think it's maybe similar in the clinics, are people who come from underrepresented communities. And obviously all of these rare dementias are pretty indiscriminate about who they affect. And so it's a really important opportunity for us to try and raise awareness about these conditions collectively so that more people get a chance of having a diagnosis or a more detailed diagnosis and finding the right support at the right time. And as part of that, we'll be sharing more information in the next few months about a kind of volunteer scheme called RDS Champions, where those of you who might be minded to in your local community, we might support you to try and talk more about some of the issues that you've faced and the challenges that you experience. And that's something that we'll be developing over the next few weeks. Nick, as Nikki and I go to sit down, do you want to say a word about the centre?
I'll just say something very, very briefly, but I realise I'm standing between people and refreshments, which is always a bad place to be. So the danger is, once I get started on this, you won't ever get it. I realise that. So, why are you in this room? The reason you're in this room is Nikki and Helen and others spent ages trying to find somewhere where we can hold this meeting. So, RDS doesn't have a home. It's amazing, it's been done. It started with the odd research assistant, or Seth, or me, or clinical fellow, or Natalie, or Phil, just giving up their time to try and host a meeting and deal with emails and contact other people. And that's true whether it's familial Alzheimer's disease, or posterior cortical atrophy, or frontotemporal dementia. And these have grown. And who here ever went to those meetings we had at the Welcome Centre? Yeah, a few people. Provided tea and coffee and biscuits, and there was lots of space, and they helped make it was easy. And we realised that the RDS has been too successful. And then somebody said to me, why isn't there a Maggie Centre for dementia? Does anybody know what a Maggie Centre is? Yeah, so to my shame, I have no idea. I said, what's that? And Maggie Centre, some woman called Maggie had cancer and fundraised to create a centre which supported families going through chemotherapy or getting a diagnosis and recognising that being told a diagnosis in a, frankly, windowless, slightly smelly clinic room that I'm usually in, and that's not to do with me, where people are interrupting and coming in and out, and you then say, okay, bye. You go back to Aberdeen or Aberystwyth or wherever. Just couldn't be right. And so the idea was, and the same is true for the Maggie Centre for Cancer. So the Maggie Centre concept was not in a non-clinical space that would feel like home, people would get support for whole families. And so that's what we want to do. We want to create the first in the world. And the Maggie Centres were started with one hospital. There are now, I think, 26 and 3 international, and they're all being raised because once they start and people see the success, other people fundraise for them. And they then
create a knock-on effect. So we want to do this, and the National Brain Appeal is a charity holding the pot, but also helping us raise money, and with a target of, dare I say it, 7 million, though we'll do stuff on less than that if we can, and that's what we want to create. We're looking for a building at the moment, and engaging with people. So to your point, Chrissy, about other things that you can do, we need people who can be willing to just talk to a donor, or explain how things help, and I want to have a bit of time at the end to talk a little bit about what this group feels we should be doing more of, including what you say, Chrissy. But
All right to them.
yeah. Yeah. So it's tea and coffee now, and I'll pick up questions from this when we get back. I think it's just out there. Okay, we'll make a start. People probably have got those. So we're sort of kind of mixing a few things together. I think Natalie is going to start with Liz about the international family conferences, which obviously not as good as this.
Welcome back, and it's really lovely to see you all in person. And we haven't covered this today, so just, I'm sure everyone knows, but dominantly inherited Alzheimer's disease and familial Alzheimer's disease, all the same things, but it's probably a bit confusing when you first start getting emails from various different people, say, using the different terminology for the same thing. So I'm going to talk a little bit about the dominantly inherited Alzheimer's disease international family conferences. Now, anyone on our email list should have received an invitation to this, and if you didn't, then I'm sure Helen will be able to send one out if you've joined our mailing list later. And some of you are very familiar with these, and I know there are people in the room who've been to them, but if you're newer to the group, you may be wondering, what's this event? How does it fit in with the other groups like this one, the other opportunities to meet families? And so I'm going to give a bit of an introduction, and then Liz has very kindly agreed to say a few words. And Liz has been coming along to our support groups for the past 12 years now, ever since the very first one, with her husband and daughters. And so really grateful that she's going to share a little bit about her perspective about what these different opportunities have meant to her and her family. So when I first joined the Dementia Research Centre back in 2008 as a research fellow, DIAN didn't exist yet, and we were seeing people with from families like yours in clinic and in research, and they would often say to us, are there really other families out there like mine? Because most people I've met have never even heard of it, and it would obviously be lovely to be able to meet them. So led by Seb and Nick, who put in an application for a public engagement bursary, we organised this first meeting back in 2010 as an opportunity to bring families together and as a chance for us to learn from them and for them to learn from us. And you were there, and a few other people in this room were also there, Martin at the back. And the group was a great success, and so we've carried on having annual meetings. And I have to say, in those early days, we're really indebted to the efforts of a few people in the group who gave their time and professional skills to put together the first website, make newsletters and make educational videos, until the development of Rare Dementia Support, the amazing umbrella organisation that now is doing so much more and has really added further momentum to the development of opportunities for people to get together. So at that first meeting, the talk I gave was about international research studies, because the DIAN study was just about to start. And at that stage, we were the only site in Europe, along with a few sites in Australia and across the US. And as Cath showed on her slide this morning, that network has really now grown massively. And as that study got launched, initially it was a natural history study, so studying individuals at risk to learn more about the disease and to really lay the foundation for clinical trials. They too realised the great importance of bringing families together. So in 2015, the International Family Conferences were launched. And so they take place every year, the day before the Alzheimer's Association International Conference, which is our sort of one of the main research conferences in our field. So the location changes each year, along with that, the location of that conference. So the first one was in Washington, DC, then in 2017 it moved to London. Nick did a huge amount organising that one, and there were amazing talks from Sophie, and you were on the expert panel for that, along with me and some of the amazing geneticists who found the first genes for Alzheimer's disease. So I certainly felt very humbled to be sitting up there. And then the last face-to-face one was in LA, and Liz, you were there, weren't you? And there were plans for the 2020 meeting to be in Amsterdam, but a small thing called COVID happened, and so it's gone online for the last 2 years. But so yes, what's the aim of the family conference? Well, really it's to provide family members with information, support and opportunities to share insight with each other and with researchers like today, but also, and I think this is a really key difference, with pharmaceutical companies, with representatives from government funding agencies and regulators. So these conferences are big events. There's hundreds of people. I know that over 200 people have already registered for this year's conference. So it's a really powerful forum, I think, for influencing what happens with the people who get to make those decisions. So the morning is a series of scientific presentations and also family presentations. So a number of family members will come up and give a PowerPoint presentation about how the disease has affected their family, and they're from all over the world. And there's updates on trials and then expert panel question and answer sessions. Everyone has lunch together, and then in the afternoon it's just for family members and their supporters, in a series of smaller practical support and information sessions. And I know that some of the things they're planning to discuss this year are genetic counselling, caregiving and life choices, particularly for younger adults from families. And that session is going to be sponsored by this group, Young Timers. And I put their website there because I think this is, I don't know if some of you have looked at it. I think it's actually a really nice website, and it's put together by some young family members in the States who got together and wanted to create a resource. And they're very active in the organisation of this conference as well. So it'll be on July the 30th in San Diego, but it's also all recorded, and they're looking into live streaming options as well. And I should say that all of the previous conferences are all up there on the website, and I can share that at the end again. So if you do want to look back at past meetings, it's all there, along with some other resources. So it's obviously a really long way to travel, and I hope that, I don't know where next year's meeting is going to be, maybe Nick does. I don't think it's been announced yet, but hopefully it'll be somewhere a bit closer to home. But if you are interested in travelling there, I know there are still places, and there is support available for people who are either travelling for the first time to the conference, or if they've been to a family conference, for example, the London one, but not claimed for travel, they can also apply for funding. So for 3 nights hotel, contribution to up to $1,000 for travel, and that's for each at-risk or affected individual, and also someone to support them. And support people of symptomatic family members who can't travel will also be eligible for that support. And any questions at all, the team organising it are really happy to be contacted on email, and I've been in touch with them over the week, and they're really keen that we spread the message that there's still space, and obviously watching it online I think the previous conferences have been really well put together with the online provision as well. So. And I should have mentioned there's a social event as well, isn't there, which is a key part of it. So, Liz, I was going to turn to you now. Maybe I'll sit down so it's less strange. You've been coming along ever since that first meeting, and I think there were about 15 of us in a room in UCL, and you've seen how things have grown, and you've always been really amazing at feeding back to me on the things that went well, or the things you'd like to be a bit different. And then obviously it's quite a different event, the family conference. So what have you and your family taken from these experiences over the years?
I think, well, the first one was like you asked us, we came up, Mike was diagnosed, and we came up, he was doing research for the team then. And you approached us and said, would we be interested in a support group meeting? We went, God, yes, just to be able to talk and know that there was someone else out there that was going through this. The girls were very young at the time. They were only
15 and 13. They had to remind us how old they
were. So they were very young, and I said yes. I said to Nick, could the girls come? And Nick was very hesitant, and he went, oh, I don't know about that. And I said, look, we've been very open with them. They want to come, and you wanted to go back and discuss it with your colleagues. And you said yes reluctantly, as long as they would walk out of the meeting if it got too much. And I mean, I know that you have since said, thank God they did come, because they participated, they asked questions. And the thing that we have taken out from, I mean, it was in a little room, we were in a little semicircle. There's a few of us here today that were in that first meeting. But it was just every meeting that we have come away from, we have been filled with positivity. It's never been a negative thing. It's just listening to all the guys talk, and as the meetings progressed, there was lots of different people who did talks. And I remember Selina's first talk, and it was just so animated. It was fabulous. And it has just been a positive effect on the whole family. And we've come away from every single one feeling good. We've never felt negative. And I think from the girls' perspective, knowledge is power. And that's how they felt. Then we did go to LA. That was a completely different feel. Don't be put off. I remember looking at it, and I was a bit put off with the intricacies. I know that you probably remember we talked about it, of how to get the tickets, and you think, oh my God, I've got to pay out for this, and then you've got to claim it back. The guys who you contact, they're really helpful online. You do get all the money back. It's just a little bit of a weird way how they deal with it. I enjoyed it, we all enjoyed it. And some of the American scientists blinded us with science a little bit too much, that at some stages we were sat there. All the guys here who talk about it make it so easy to understand. They went over our heads a little bit too much, but it was fantastic going to a conference of that size, knowing what's happening in the whole world. It's not just happening here, it literally is happening everywhere we go. And again, it just fills you with positivity for the future, and for my children and what's going to happen. And I just think, if you know people who've not been to one of these meetings, please tell them it's not scary, it's fantastic, and you go away, for me, feeling empowered that I know a little bit more. And from where we began 12 years ago to today, listening to Cath, even from the LA conference, I'm blown away as to what's happened over the 2 years, when I kind of think, you think, oh, COVID, did it all go into lockdown? But no, it sounds like it's just amazing. So,
no, thank you. And I don't know if anyone else, I know there were other people who've been, whether anyone else wanted to pitch in, or, it's a different group to this. I see them as very complementary, and I think you've really sort of highlighted that. I would be interested to know if you managed to meet many other families when you're out there. I know through the social events, there's a bit more time probably for the conversations, or was it sort of a bit too big almost?
I think, it might have been a bit too big. I know we all kind of kept together a little bit, didn't we, the UK team. We did talk to others.
Yeah.
Some stranger danger.
Yeah. But I mean, they asked for feedback, and one of the feedbacks that the break-off groups weren't managed very well, or our break-off group wasn't, which was a shame. But you learn from all these things. But yeah, you do talk to other people, and it is so beneficial. And as I said, it's just so nice to see that so much is being done, and it's worthwhile going if you can. It's a long way.
Meeting group, don't they, the night before?
Yes. Yeah. Yeah.
And it's free drinks.
Free drinks.
It's a right away.
And I love that comment that you made, that the main thing, you always come away with hope, and I think that just harks back to some of the things we were talking about this morning. And I apologise that the agenda has slightly got off piece, but I think that's actually a sign that things have gone well, that we've not been ruled by the agenda. But I know that was something that Emma said you were going to touch on anyway, hope and hope particularly in the at-risk period of people's lives. So
it's a perfect introduction, actually. So,
sorry, Nick, I've seen
everyone
the
said
cherry.
everyone said been really tolerant of me, totally messing up sharing, keeping people to time. I think it's fair, but never mind. So you're going to kind of cover a couple of sessions, kind of all lumped in together. Is that right?
I think so, yeah, if people are all right with that at this stage of the day. It's very warm.
We've all forgotten the agenda, didn't we?
But it's quite a nice, I guess it's a nice thing with the hope that it had already come up so naturally in other people's conversations. It's almost like, oh, we've had a dedicated talk for it, but actually it's so much a part of, you know, all the talks that have happened and like from your personal experience as well. It's just, yeah, it's so clearly part of the field here, and I think especially with trials and on a difficult journey like this, hope, you know, it changes the sorts of things you're hoping for, and you know, there's a lot of renegotiation of that hope, but finding a way to hang on to that, future focus and positivity, I guess. People do find ways, and it sounds like especially collectively there's something in the sort of social connectedness that really helps to bolster that, which is so great to hear.
And I think the other link to what Emma's going to kind of go on and talk a little bit about now in terms of living at risk is actually that was when we were thinking about what would be helpful to talk about today. Living at risk was one of the topics Natalie pointed out had been raised at one of the previous family conferences. And so it's not wanting to sort of end the meeting on a downer in any way, but also just to make sure that in every meeting there's a space for people to talk about what's actually on their minds, the good and the bad, the tough and the celebratory. And so that's what we thought we might spend just a few minutes doing now, if that's okay.
That'd be great. And lots of people know Seb, and I think quite a few people know Emma, but the risk of embarrassing people. Emma provides a fantastic psychological sort of tailored support for not just for fAD, but we certainly call upon her. So there is a service for people who've gone through the clinic or where we through RDS, where we recognise that one thing clearly for having a chat through the support group, and there's another where actually people need tailored, sometimes multiple sessions, and Emma is fantastic. So,
Emma, did you want to say just a little bit about some of your experience and the literature of when you've been acquiring these skills about supporting people living at risk, some of the themes that people have got come up with? I think you've got a few thoughts on the slide.
Yeah. And do you mind moving on there? Is that okay? And we were putting the slide together, so before anyone feels like they need to read all of it or that it's really gloomy, we were a bit tentative because we thought, we know from the literature and from conversations that there are some really challenging thoughts and concerns that people in similar situations to you are facing. And this is not trying to put, words in your mouth or thoughts in your mind in any way. We'd be really happy if people are happy to chip in if anything particularly resonates for you or you recognise it. But we do know that there can be challenges, and I think what we wanted to do today was give you a very brief whistle-stop tour of some psychological interventions and approaches that can help with some of these sorts of worries if they do come up. And we got some empty speech bubbles up here to really acknowledge that you'll have your own versions of these, the thought that really gets you or really bothers you or you can't kind of move on from sometimes. I think to carry on with the theme of hope, it was really to mention that there are challenges, but also to move on to talk about some of the ways that we can support people one-to-one to deal with those.
And maybe just to pick out a couple of examples, there may be things that are up there that really resonate for you, or things that are missing which you would put in these empty bubbles. All of these come either from our experience of talking to people living at risk, or for things that have been written by or about people living at risk. So, for example, some of the people I've worked with in the past have talked about grief and talked about, I'm grieving things I may lose in the future. and felt never before felt allowed to talk about that. They've always thought or felt this pressure that grief is only something you can experience when something's gone. We're not just talking about people, we're talking about roles and hopes for the future and all sorts of things. And so some people find it really encouraging that there are counsellors or psychologists or friends out there who are happy to be part of a conversation which acknowledges things like anticipatory grief, the grief of things that may change in the future, or ambiguous grief, grief that is difficult to kind of describe or recognise. Emma, did you want to pick out any other, or we could go on to a couple of examples?
Yeah, I think a lot of, for me, a lot of these, something that's kind of at the core of them is this sort of jumping into the future. A lot of these worries are kind of, there's that theme of jumping ahead, maybe worrying about the future, thinking about the future. And so some of the techniques that we'll talk about, if you have to look at them, is really about learning ways to be in the now, which sounds, double challenging. Some people hate that when they've had it. Just be present. But it is true, that there is the future, and there are things that might be worrying about that. But we're here now, and it can be really helpful sometimes to, as a way of disengaging with some of those worries, to just come back to right now. How are things right now? How are you right now? And there's one particular technique which I said was going to demonstrate, that you'll be grateful that we don't have time for you to do this. If you think about, say, if I was to look out this room and all the things that matter to me in my life are in front of me, also all the things I've got to do on my list, all the problems in my life, all of these things are out there in front of me. And if I think of my hands as being my thoughts and feelings, they're also here. And when I get kind of preoccupied and hooked into those, they sort of move up here like this, and they really obstruct my view. I can't see those things which are important to me. Maybe I can't do those tasks that I need to do. I can't confront those challenges in front of me because all I'm seeing is these. And I think what we're trying to do with psychological therapy is just find ways to move those down and disconnect from them a little bit. We're not chopping off our hands, they're not going completely, they're still here, but they're here in a way that we can still see what matters and what we need to do, and we can use them maybe if they're helpful. Sometimes they are. But yeah, I suppose that's the process. We want to sort of instill hope that there are ways that even if there are things that feel overwhelming and pressing, that you can't disconnect, because there's ways we can just create some space around them, I think. One particular type of way, which I think is maybe not what everyone wants to do at the end of the day, is a bit of audience participation, especially in such a hot room. But a small example of this is like a grounding technique. Some of you might have heard of it. It's about getting into the moment. It's about at any given time thinking of 5 things you can see, or noticing 5 things you can see. So we'll try to do this now. It's 5 things you can see. 4 things you can touch. That might be the seat underneath you, the ground under your feet, your glasses on your nose if you wear those. 3 things you can hear, 2 things you can smell, 1 thing you can taste. And it seems very simple, and it maybe seems very trivial, but when you're really up in your head, it can be really helpful to just actually remind yourself, oh no, there are things over there, there's noises. It's just about shifting your attention sometimes. Can be hard to remember to do it when we're caught up in those thoughts, but yeah, it's just another example.
Does it matter if you want to taste 5 things and they're looking at us when you say see 5 things, I'm usually sitting in the garden, and then the second thing is like looking at the hanging basket and think, oh, I need to water the garden. Hours later, then I'm empty the bins and think that kitchen oven, being upstairs and having, what was I doing?
And that's sometimes those thoughts can be, and you need to get back to your first thing you can see. And then all sorts of other approaches as well, because I know some of different things work for different people. So breathing is a really helpful thing. Some people think that sounds too basic, how can it possibly be helpful? Other people think that's basic and it can help, that's brilliant. So lots of breathing techniques that can kind of just override if your body is in an anxious state. It's a really quick way to tell your brain, I'm okay and things are okay. Even if they don't feel like they are, you can trick it, which is very helpful sometimes. For those of you who are a bit more problem-solving and practical, there's things like CBT, which you've probably heard of, cognitive behavioural therapy, lots of worksheets, exercises, the sorts of things that make me feel quite stressed, but might and yeah, another really helpful way to engage. And I'm conscious that we've been talking a lot about individuals, and imagining you on your own, but there's also kind of more systemic and family approaches that Seth is going to say a few words about.
Yeah, I guess the long and the short of what Emma and I are trying to say, there are lots of tools and opportunities out there. And Natalie and Liz have described the value of big group meetings and the opportunity to be with others in community who share something similar and hear about practical progress. We've heard from Nikki about the direct support team and sort of practical emotional support, one-to-one, dealing with particular practical problems. As Emma's illustrated, there are loads of, or as we mentioned with Helen and Emma running together now, these small groups of those of you who want to meeting together regularly to share experiences in a slightly more intimate setting than you can manage on a big day like this. And there are also individual approaches, some of which Emma has also illustrated. But we just wanted to flag as well, of course, we're really conscious that for lots of you, something incredibly complex like fAD or the experience of living at risk can essentially mean that for you and your family members or other people close to you, that you have wildly different views of this complex thing. They're both equally valid, they're both correct, but sometimes a psychologist can be, or a therapist or a counsellor can be helpful in just helping to step into that situation and helping to align views or help you understand why someone else in your family is perhaps reacting incredibly differently to what you view as a common experience, or where you think there's an obvious way to respond when they seem to be wanting to steer clear of a meeting like this, or engaging with the idea or information about your condition at all, or to having really, really different reactions as to how best to support someone in your family who's living with dementia. So it's just wanted to say there's no kind of single prescription. It's all about finding things that are right for you. We just wanted to sort of offer up some of those opportunities as an encouragement for you to think, maybe not now, but maybe in the future, that maybe there's something that would be helpful for you to be able to talk out or talk about outside of your usual family or friendship circles. If you just click onto the last slide, do you want to just say once?
Yeah, so I think the points we're making just as what, so to summarise really, that we know there are challenges, but just to reassure you that there are a range of ways of working with those, and that one size won't fit all. So yeah, if nothing here today is time with you, don't write us off. If you want to talk to us about what your issues are, how you like to work, we can help you figure out maybe what might be best. And different ways of accessing support. So we're piloting a small psychology service within the clinic that Nick mentioned, but also via your GP, through the NHS, but there's also charity, other support organisations as well, the RDS direct support team that Nikki spoke to, loads of resources and signposting and emotional support there, and also if you want to find a private therapist, you have a very specific way you want to work, we can help with that kind of navigation as well. And lots of things like apps and ways where you don't have to engage with someone else if you don't want to. But yeah, we're just happy to talk about it if you're struggling to let us know.
Great, well, thank you very much. Questions, comments, all very welcome, acceptable. I think Sophie once said something about that. No, not the really bad stuff, Sophie, I won't mention it. It was something like, and I won't say as well as you did, it was something about whatever you feel is...
In any given moment is okay.
Everything is
You will
okay.
differently at different times and
There's it's not right or wrong, it's just, it's okay that you feel that. And I think one of the things that perhaps this group really is further along because you've been willing to come to a meeting like this, so you're really acknowledging, accepting, and you know members of your family or not. But that sense that it's okay to acknowledge whatever you're feeling, and then
if you've taken that step to recognise that actually there are supports, techniques, could be talking to your friend or partner, but it might also be some of the things that Emma and Seb and the rest of the team actually very modestly describe, because they make a huge difference to a lot of people. So everyone, it is a bit biased, but I think they do a great job. So questions, comments, anything?
Just moving, sorry. One of the things I've experienced is a sense of entitlement or not entitlement to need support and feel bad when you don't know your status. If that sort of makes sense. So my brother's got it. Is it reasonable for me to worry? Because other people say, well, you don't know if you've got it yet. You don't know, you know. So then you think, okay, I'll shut up. And then you don't. It's just this mess of this limbo as to, and it is a sense of entitlement. Am I entitled to sound really worried when other people actually know they've got it? They've got much bigger things to worry about. And it just does amazing sometimes. So I begin.
Then you can do one thing you can taste, is your gin.
That's what Sophie said on my phone. She's just like a gin.
I should have put that as maybe number one. I think absolutely, just to validate and legitimise your worries, and sometimes we talk about primary and secondary kind of emotions, and that you might have primary feeling, which is the worry, and then if you add a secondary, oh, now I feel bad that I'm worrying, or I shouldn't be worrying, it just exacerbates it, and it's just another level for you to manage. And I think exactly as Sophie was saying as well, anything you're feeling is valid and legitimate in your circumstances. And actually stopping that critical voice of yours, which is telling you that you shouldn't even be feeling it. That's a lot of the work we do with people, is around that, just to reassure you. And I think that's why peer support is so helpful as well, because it's like from Sophie and others, you'll hear other people say, oh, I get that too. That can also be another way of sort of validating.
Completely endorse that, and all the years I've met families, so common for people to feel they shouldn't feel something. They shouldn't feel guilty that a sibling has got the gene and they don't. They shouldn't feel guilty. They should feel, they shouldn't feel bad. They shouldn't feel anxious. That they shouldn't, with or without the gin, whatever feeling is okay.
How would you recommend, if you're going to your GP and you're getting talking therapies or going to find a counsellor, how you can educate the counsellor or the psychologist on what you're going through? See, because one of the barriers is that you've got to tell that whole story about your family history, and by the time you're finished with that, you're exhausted. You really need to go back.
Probably outside.
And Kate mentions that you end up having to educate them and counsel them at the end, because there's.
I've had that. I didn't know that could happen. Oh gosh.
Yeah.
You're probably the only person I've got who's gone through anything. I go, oh thanks.
Yeah.
I'm at the top of your tree. That's really helped me.
And then they're like, oh no, that's Wednesday.
Yeah, and then
You've got a
you
whole week
end
to
up,
worry
yeah,
about.
you end up telling them, and they end up going, oh my god, you're going, no, I'm here, not for you, for me, and this is, and doctors.
If I can hijack that briefly, because one of the things, so Maggie centres for people with cancer are about support. And when we all first moved to the idea of to support groups, I remember the first meeting when we suggested it, about what was important. What was very, very clear was, while support was really important, a real sense, which absolutely chimes with what you're saying, Katie, is of that we need to educate GPs, we need to educate opticians, we needed to educate specialists, as well as, because these are rare and unusual conditions, and you're only going to get the support if those people you're going to see have a bit of knowledge. And so for this pipe dream vision
hope that we've got to create a rare dementia support centre at Maggie's for Dementia is going to have 3 pillars. One is support, just like Maggie's do. The second is around education, that is, and that's with families, because actually you all are experts. And then the third pillar is research, because that's our bias, because we come from that sort of background, but we think the right way to do support, the right way to do counselling, the right way to do education isn't just, I think I know the right way to do this. And that's the same about all the other things that we must suggest, but it's actually, we need to work out what the best way, and that involves research. It doesn't have to be, super clever brains in a dish, but it's, did that support group work? Is this the best way to educate opticians? I don't know. Those are the three pillars.
If I can dive in and just say the centre may be a pipe dream, but the sort of support I think you're talking about, Michelle, is already available.
Yeah.
In the sense that Nick's absolutely right, part of our mission is to educate people, but equally we're conscious or realistic that not every person with every specialty is ever going to become a rare dementia or an fAD specialist. So consultancy is something we can offer already. So Nikki and the team already spend a lot of their time working with other, for example, dementia advisors or social workers who are really motivated. They're the right person, they've got all the local knowledge, but they haven't actually met someone with fAD before. And so we can just provide that bit of extra sort of specialist top-up, focus just on them. Anna Volkner, who's our speech therapist, is another example. She works with speech therapists right across the country.
She knows them all.
Sometimes one-to-one, or sometimes with the person, in this case with the language barrier of dementia. So that we can not try and do everything ourselves centrally, but that you might find someone who you really get on with as a therapist. Maybe MRI could have at your invitation, have a word with them, put it together alternately. So it's that kind of how can we take the knowledge we've got and spread it in the most practical.
So if you found someone who can put them in touch with you, you can have those conversations.
And would you say about medics as well? I mean, we have people who are
like with your GP.
GP says, and we have heard appalling stories from GPs and specialists, including people saying, "Oh no, you can't have Alzheimer's disease. You're too young." Chris.
Sort of going on from that, something that I've never really understood, it's basically all of it. No, Cath reminded me of it in that when she was talking about finding it earlier by the pathology with the secondary interventions and the primary interventions.
Yeah.
The primary's like going back a long way. But then, in reality, how does that then work for people? Because with normal medicine, you're ill, you go to the GP, and he says, "Oh, take these, and if you're still alive in a week, come back and see me." But with something like that, people aren't going to refer themselves 20 years before because they're not going to know. So how does primary intervention work across the board?
Yeah, so it's a great question. The way it will work first is because of you. Because you, Anna, will make the connections with other families. So people will know, not when they are already diagnosed, but when they're 18 or 19 or 20, if they want to know, that they have this risk, and then they will be the people. And this will be the thin edge of the wedge that drives prevention of Alzheimer's disease across the board. Because once you can show that you can make a difference, and that will be through all your family, and that's why I'm unashamedly wanting you to go and spread the word. When that happens, that's when people can do screening tests. People get statins to reduce their cholesterol, to stop them having a stroke or a heart attack. That was only possible because people did the trials as soon as they could. They were beneficial. And do you know how they found that statins worked? And I mean, they're the most widely used, probably a lot of people here on statins, so maybe, but you may know people. They're the most widely prescribed drug just about in the world. And they have massively reduced heart disease and stroke. It was on the rare familial people who had a gene for high cholesterol. That found the statins. And that then led to them being used, because once you know that something works in a trial, then you screen the population. And we have blood tests, we have scans that could screen people all over a certain age if we wanted to. That's where we'll get to eventually, because but we're a long way from that.
But wasn't that like with the statins, like the government then got involved and were encouraging people to
get their cholesterol tested?
Is that gonna?
So
is that how you said? Because at the
exactly,
moment,
but you have to show that something works and makes a difference. So we're at that stage before the government can do that. We're at that stage where we will run the trials that Cath has talked about in people who know they have a family history, who will go into studies early enough. And if that shows the benefit, that's when you say, I mean, nobody would screen for breast cancer and do mammography if it hadn't been proven at some point that you made a difference to people's lives and futures. And that's the stage we're at. We've got to show that we can do something, and then we can screen for it. You can't screen if you haven't got anything to offer people.
Yeah.
Seth, what do you think?
Yeah.
We should repeat the
Yes, what was
question.
the question?
The question was from Michelle. Well, can you say it again, Michelle?
Yeah, I just wondered if we could have support.
Should there be a
group for
support
children.
group for children?
Yeah, I think that's a really good point, and the Huntington's Disease Association do have young people's groups. And there's an amazing professor of nursing who's spoken to this group previously, particularly on talking to children, and she's looked at this in a lot of genetic conditions. I went along to one of her family days where they use lots of different activities to just open up discussions, and we had actually invited her today. She couldn't come for various reasons. So one of the things we're planning to do in one of our online sessions is a focused discussion group about this, because she's actually one of the few people who's done research in this area about is there any evidence out there about the benefits of talking and the impact at different ages. And I think it's an area where we need a lot more research, but there are some really good resources as well. The Alzheimer's Society have a website for talking about dementia for young people with different sections for different age groups that just, I think, has some quite useful techniques and language. If they want to learn, go somewhere, you want to be able to direct them to the right place. Sorry, there was a question.
I was just going to say, my mum, her symptoms started when I was about 10, 11, my sister would have been about 14, 15. We never ever would have confided in friends at school, because no one there, in my mind, would have understood what it's like to have a parent with what they would have considered an old person's disease. So, and we didn't have any other parent at home, so if we hadn't had our aunt to confide in and speak to about it, we really just would have been left in the dark and on our own with no support, and you feel vulnerable anyway. If you don't feel like you can talk to anybody, it makes it even worse. So I definitely don't think you should keep young people in the dark. Your family, if you can support them and talk to them, please do, because I knew there was something wrong with my mum, and I had no one to talk to until our aunt came and said, "Girls, is there anything you want to say?" And we were like, "Oh my God, yes." But we were never going to tell our friends that at school. So I think just bear that in mind, that they do know when you're that young that there's something wrong with your parent or your family member, and you really do probably want to talk about it to someone.
That's great advice, and again, I've heard that echoed so many times. I mean, children do not.
It was like instinctive. I knew something vulnerable about
share
her.
that.
And how do you tell it to your 11-year-old friends? My mum's vulnerable. There's something wrong.
Children are amazing at keeping, probably not just in Alzheimer's, but in other areas, keeping dreadful things that are happening at home completely separate from anybody at school, any sources of support.
I think as we evolve this group, like hearing where there may be gaps and hearing from younger people about how they would like to be supported, and I'm so glad that you came along and spoke about that experience. And I think that we should be asking you when we're been through it.
It's like, I don't have anybody at school who has a parent with Alzheimer's and no other parent at home. Like, who do I talk to? So that's why my family's been amazing. My aunt's amazing. Sorry, but she is. But we would have been like completely alone.
So yeah, and we would have had that burden, we wouldn't have been ignorant to it, we knew it was going on. So yeah, that's.
But yeah, maybe it's great, because there's a lot of stories here, people, like we're adults now, and we've all been through this journey as children, and coming through it and seeing parents, and maybe we could add to, yeah.
No,
Well, maybe there is a need for a group like my age, you and, you know, the younger.
I think it would be really great to capture that, because if you felt strong enough to, you know, it's hard enough to come to the meeting, never mind to keep thinking about things from it after you leave here, but actually that's really powerful for other people.
I had a similar situation to you when I was at school. My mum was unwell. I'd go, you know, sleep over at your friend's house, and one of my friends eventually was, why were we staying at mine? Why can't we stay at yours? And I was kind of like, okay, this is the situation. And his response once I told him was, well, I don't care. I was like, it's not about you not caring. It's that, you know, it's we just can't do that at my house. But yeah, kids, they don't get it, do they? So some of them, when they're detached from the situation, don't really understand it.
And even if you know there's stigma about it, so you sense it. Like, oh, my friends didn't think that I got clean for uniform, or I have to do it, and I'm feeding me. Like, that was like this embarrassment.
Yeah.
And you don't want to speak to your young kids about that. You only really want to people that understand it and know about it.
Jason?
I was just going to say, I've got daughters that will be 11, one's just turned 11, will be 14. So they have very early memories of my mum, and we always talk quite openly. If we come to this day, we don't hide. I'm not hiding the fact that they ask, I'll talk them through some questions, and they're quite open. But what was really interesting, I was just reflecting, because my wife's dad passed away in COVID, but he was getting signs of old age Alzheimer's. And the girls were really good with him because we allowed them to understand. So when you're eating, you're struggling, and they were really good at understanding what it does. And it's amazing how children cope when they understand what the issue is. And sometimes we have our own concerns about sharing, but if they want to ask, we don't burden them, but if they ask, we give them the information. And I think it's amazing what they can take on board. And I think the support group is quite good if they wanted it, if that makes sense. Because some kids are not ready for it, and they go, if they want to know something, they'll ask you. And if you try and hide it, it makes it more work. And then they worry about it more. But actually, it was really interesting seeing how they engaged with Father and Mike just when you had it. And our mum's now a little bit like that at home, but they understand that this happens in life and it can happen at different stages. And it's a thing. So I think hopefully as they get older, it doesn't affect them, but they'll understand that these things can hit you at different points in your life. And then they know it's quite normal in many circumstances. So it's just interesting seeing the perspective. And I think if it's an older person, you would embrace it more naturally. I think it's this piece about being young, because I definitely feel from my family history, it was almost we won't tell anybody because it's a bit awkward and we don't know how to explain it. But I think moving forward, I think making it really explaining it, having a young person walk down the street and it bumps into someone, it's really hard to explain, but actually if you could share that knowledge and open it up to younger people, now it just helps.
Olivia was actually where I got a phone call from Olivia's primary school. She was in secondary school now, but primary school to tell me that she knew too much about Alzheimer's. I was like,
You know too much. Yeah.
Living it.
Yeah.
Imagine having to live it. But she's known from quite a young age, and she did suss it out. I think she was about 8, and she was like, "So Nanny had it, great Nanny had it, but Nicole's got it." And she was like, "Are you going to get it?" So she kind of sussed that out, and I didn't really know how to answer. I just looked out the window, and then I was like, "Oh, there's a possibility. Yeah, there's a 50% chance." I said, "That's why we do the research, because that's what's important, is to make sure that you're involved, and that's how I kind of approach it."
And you've got nice information in this group that says there's stuff happening.
Yeah.
So if you answer the question, it's not just a negative, it's a negative, but this is happening. And actually, we're talking earlier, weren't we, that actually the answer in 20 years' time is very different to the answer now, which is quite exciting for future
I was really
generations.
context education as well, kind of teachers and stuff, that it's not just adults going through this, like children, young children are going through it with their parents, and I don't think schools are going through it at all.
No idea.
No.
I completely agree.
But also, you know, like if I think it was 12 years ago, and
it was the DIAN study was only just starting. I remember you asking if Mike would go on it, and then Selina came and she said, I want skin cells. And she was so excited. And I mean, that was during my journey through it. And then Mike said he wanted to do it, and then he took a massive downward turn, and he never did. But to hear her today, and I remember you all explaining it was a button size, and to hear today, and that's only in 12 years. And you know, from that first meeting to now, it's just like, wow. And it is in really a short space of time.
It's really nice that if you are having conversations with children, you can genuinely be so positive now. And what you were talking about this morning about control and how knowledge and information gives you a sense of control, I think children benefit from that as well. That if they know what's happening, they know someone's doing something about it, and that their family is going to be right at the top there when things are available, then hopefully that then lets them just go and think about other things
We
for a
need to
bit.
break down the stigma on that one as well.
Yeah,
Because it's
absolutely.
like, everyone talks about cancer very openly, and now
Yeah.
HIV, which used to have obviously a big stigma, but it feels like it's not been broken without science yet, and that's the biggest problem, I think, just keep hiding it. That's another topic.
Yeah, no, so Nikki, I wonder
Yeah,
whether you want to comment, because you probably get these questions, not just in the familial, just, we have a shilling cart open the window.
Yeah, just with some of the other groups. So, case study really, a lady a family that I'm supporting. It's not genetic, but she has FTD. They've got a fantastic family and friends network around them, but she's only 33. All the family and friends have got young children. I did an amazing session recently, and I'm so lucky. I love my job so much, and I always find some other things that I really, really love. And this was just the most amazing session. The school set up one of the boardrooms. We had about 10 kids in there from age 4 up to 14. They put us on the big screen. It was like a Zoom sort of thing. We made this educational session with Bertie. Bertie Brain was there because she said GT. So the kids were telling me things. What happens when you go to the house? She steals our sweets. She smacks our bum. You know, all these sort of things. And they asked us the most amazing questions. And we really got this discussion going. And all the parents were there as well. I'll just say that for safeguarding there. All the parents were there asking questions, and what a difference it has made to that family's life. Because, like you said, Peter, you can't have your friends home. They didn't want to stop this. The kids were still there. They still wanted to support as much as they could. But the kids could go around now and think, right, okay, got a bag of Maltesers. What's her name's going to steal half of them, so that's fine. I'm not going to get upset about it. But having the school on board to allow me to do this session was just amazing.
Thanks, Nikki. So I'm mindful of time and people need to get away, and I don't think we'll get kicked out so people can carry on talking, but there's a few things that I wanted to say. I want to thank all the people who contributed, not just people from this side of the room, but from this side of the room, which is amazing. I think I'd like to spend just a couple of minutes if people have got just thinking about, we've had some great suggestions, and we've also got feedback forms, which we want you to fill in and leave. But what we need is thoughts. Chrissy was sort of saying about we need to make it more aware about who we should be fundraising for, making that very clear. And I think, Steph, you're willing to say a couple of words about that. Fill in your forms now if you don't pass out from the heat. And then would like to talk after Steph talks just for a moment about what you want from these groups, what other things we need to do apart from air conditioning. And I think we've already some great suggestions about ideas for fundraising, how we create a group for children, which I think is really needed. I didn't even want to share with you the many stories I've had about, since I very started, about stories of
either children or parents have told me. So, Steph.
Yeah, so I just wanted to properly introduce myself. So I work at the National Brain Appeal and my name's Stephanie and I work as a fundraiser there. So if any of you are thinking about raising funds for Rare Dementia Support or for the Rare Dementia Support Centre, then I would help you through that. You know, maybe you don't know what you'd want to do, so I can help you find inspiration and suggest events or fundraising activities that you can do. We've got on our website, the National Brain Appeal, we've got loads of events that you could take part in. So we've got you could do a sponsored walk, you could do a swim, could be something like a cake bake Saturday or a coffee morning. There's so much that anyone can do, and it really makes such a difference. And I'm there to support you if you do want to raise those funds. So yeah.
And you can say exactly what you want them to go towards.
Yes.
You know, if you say, I want to go towards research, or I want to go to RDS, or I want just for FAD, or whatever, that the National Brain Appeal is great at making sure that you can say.
So if you want it for the centre specifically.
Yeah.
I'd
say
exactly.
Yeah.
You can do that.
How are you on the raising funds? Where are you?
There's one other thing.
We do have an anonymous donor who's also match funding for £5,000. So people that want to raise money, that will be matched. So
And that's just come in, hasn't it?
yeah, so that's
So it's untouched. So anything up to £5,000 gets matched pound for pound. So
yeah,
like 2
for
for
the
1.
residents, so an extra reason
What's
to
the
do it.
timeline on that then?
When it runs out.
Yeah.
So it might be gone by tomorrow again. Yeah. So then skydive you're planning? Don't worry about this gathering momentum. Actually, gathering momentum is a bad idea.
On your feedback forms, please do feel free to say things you'd like to see Nick do for money.
If we want to keep in touch, what's the best way to do it?
Okay, these are great questions. What is the best way?
Easy way rather than.
What's the best way?
I can facilitate that. So if anybody wants to be in a group, if you just send me an email with thinking that you want to go in the group, and then I will send an email round to everybody with their permission sharing their emails. So I won't facilitate the group for you, but I will facilitate you having the group.
But a key thing for all these things you're talking about is even if you've got one other person that you picked up from this room, that's really powerful. But the way I've seen things really take off, I mean, lots of people have an idea, but if you've got 2 or 3 people who are helping you with that idea, it usually happens. So please exchange whatever you're willing to exchange with each other who you want to, and also via this group. So I think we've got some great ideas about, I mean, Chrissy saying about, you need to make it easier for people to know what to fundraise for, how they can influence policy. We need to create a group for children. We need to improve materials. Michelle, Rachel, we need your stories about how, as far as you feel able to, about your experiences, so we can help other people.
If anyone's up for community living as well, because that's one of my plans for DIY, so we can all support each other as a nice support way. But as I'm saying, someone with no support.
And almost finally, I need to embarrass May, because I asked May is now going to self-identify. There's May. May's here. I had to host a visit for a funder of genetic research. I've got no idea what Alzheimer's is, never mind inherited Alzheimer's. Well, they probably know about Alzheimer's disease. And I could grab it onto the mic, guys. Normally do. But I thought I'd get May along, May generously came along. And what was it like, May? Yeah, people who did not know much at all, did they?
No, I was scared because I wanted to do a good job for everyone. Felt a little bit of pressure, but then it was, so much better than I thought. And I think it went well.
It went really well, and so you all, through your lived experiences, have not only great knowledge, but also you have a power to change other people. You know, Rachel said there would be nobody in the school who would have known that children could have a parent in their 30s, 40s with Alzheimer's disease. The genetic therapy people really had their eyes open by me saying, this is my family situation, this is why it gives us hope, this is why research is important. And you didn't cry until quite late on, which was really good.
Yeah.
She told me afterwards that, you know, what I'd be worried about is crying at the beginning.
Yeah. I just thought if I cried straight away, we're going to hear anything I'm saying. It would be pointless. Yeah.
Tears are good for that.
Any other
Yeah.
Just like the champions, that when we launched it,
Yes.
we are launching the voluntary champions, and we will be looking for people to actually do some talks with us. I do lots of talks sort of every month, and I often take people with me or by Zoom, and I might as well just shut up, to be quite honest, because I'm not really interested in what I have to say, but your voice is so, so powerful. So if anybody is interested in getting involved, please do let me know.
Yeah, so the one message I really want you to take away from today is there is real progress in the research and there is real hope there. These are really complex things, whether you're deciding on how you tell children or how you plan the future or what trial you should get involved with. These are complex and not easy, and we want to be there to support you on that. But also to tell you, you are very powerful. You are knowledgeable and you are powerful. And you can change what funders think, like May did, or you can change MPs. The things that make me so cross at the beginning, not just the myths, but the other things, they need to change. We need people, you've got enough daily life stuff to get through. All of us have got too much to do. You've got it all in spades compared to most of the world, but any spare you have, it'll be most powerful through self-association. If you can, help with the next meeting, say suggestions, create a support group, think about other things that you think might matter, be a spokesperson, and don't die of heat stroke.
And educate GPs. I've printed up loads of stuff for 5 years for my GP,
And we're thinking about this whole idea of people being champions, and learning from the power of other groups like HIV/AIDS, where they really harness people. US senators were terrified of being accosted by people who had said, "You promised, we met with you. What's happened? Where's the cure?" Let's take it to where the power is. And I think with that,
we're having a revolution, aren't we?
We are. There's power in you. Power in you. Please fill out your forms if you think about it. Get other people involved. Send in suggestions. And thank you for coming. I know it's not easy to do on Saturday, and it's a stressful time. Thank you. Is there tea still or water?
There's water at the back.
There's water at the back. So
And there's quite a long lunch round here as well. Just saying. Yes, absolutely. Yes.
Thank you very much.